of us here in room 100. The rest of the commissioners are on Zoom. Given it's a hybrid meeting, we'll continue to apply our ground rules for these meetings. I'll begin with a roll call of commissioners. During the meeting, I'll ask the commissioners and presenters identify themselves before speaking so that commissioners and the members of the public will know who is talking and have the same knowledge as those of us here in room 100. The commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, please, commissioners and presenters mute their electronic devices when they're not speaking. I'd also like to ask commissioners attending remotely to avoid putting substantive comments in the chat, as it can be difficult for those of us in the room to see the comments. Also, I look to see when hands, like when the little hand device is raised, but I can't always see it on the screen. So if you have a question and I haven't called on you, please feel free to say something because I can't always see everybody on the screen. And then let's see. MHCC posts documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. So on with the roll. Commissioner Bhandari.
Here.
Welcome. Commissioner Blake.
Here.
Welcome. Commissioner Boyle.
Here.
Hello. Commissioner Buzinski.
Here.
Welcome. Nice to meet you. Commissioner Douglas.
Here.
Hello. Commissioner Gilmore. Okay. Commissioner Jensen.
Here.
Welcome. Commissioner Ojikutu. Commissioner Spinner.
Sorry, Commissioner Ojikutu is here.
Oh, welcome. Welcome. Commissioner Spinner.
Commissioner Spinner will be about 10 minutes late.
Thank you. Commissioner Stroughton Duncan.
Present.
Welcome. Commissioner Wang
Present.
and Commissioner Wood.
Commissioner Wood is not here.
Commissioner Wood is absent. Okay. And Commissioners Cheatham and Gelrod are absent as well. Turning to our first agenda item, approval of minutes. Included in your packets are copies of the minutes from the October 19, 2023 public meeting of the Commission that took place in person and by video conference. I will entertain a motion to approve the minutes of the October 19th, 2023 Commission meeting.
Motion to approve.
Mr. Brzezinski, do I have a second?
Second.
I think I heard Commissioner Douglas first. Thank you. Any discussion? Okay, all in favor?
Aye.
Are there any
Aye.
opposed?
Aye.
Agenda item number 2, thanks. The motion passes. Update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates?
Yes, this is Marcia. Commissioner Boyle.
Go ahead.
Hi, I just wanted to, bring attention to the pending notice of acquisition change of ownership, that there were, 4 transactions that would not, that the commission staff concluded would probably not meet the requirements for docketing for a CON application. And also that the commission staff recommends that OHCQ consider the above information in its licensing decision. But my understanding is that at this time, OHCQ does not feel they have the authority to deny a license. So that's a bit of a catch-22 right now.
So I believe that OHCQ is seeking additional advice from their assistant AGs. I was not on that meeting, but if Alexa or Caitlin have something to add, why don't you come to the table and share it with everyone?
Good afternoon, Commissioners. Caitlin Evans, Assistant Attorney General. Yes, the OAG's office is looking into whether or not OHCQ has the authority to consider the report and recommendation and then make a decision based off that information. So we hope to have an answer to that soon.
And
But
if,
at this time,
oh, go ahead. Well,
I know, I'm just saying, but at this time, we have, 4 instances of acquisitions that this is up in the air, so, I doubt it would be resolved by the time this went through, but I could be wrong.
We haven't completed a report and recommendation yet to send to OHCQ, so we do hope that that decision is made before we send the first report.
Just FYI, thank you.
and I take it if the conclusion is that they can't consider this with their license scope, is the next step preparing to think about, a change in the law?
I think that this kind of flows into the entire work of the nursing home board group that's convened to make some recommendations on additional changes to the oversight of nursing home acquisitions that I'll talk very briefly about, but which the commission will hear at the December meeting.
Thank you. Were there any other questions or comments? That, Mr. Executive Director, do you have any updates that were not included in the monthly updates?
Thank you, Chairman. The first thing I wanted to bring to your attention, I know last month we had a presentation on ambulatory surgery facilities in Maryland. There was some additional information put together by Teresa Lee's team, and I wanted to bring your attention to it. Kind of again reaffirmed a different operational environment in Maryland than exists in many states. We continue to we look on a per capita basis and look at not facilities, but ORs. We do rank as the state with the most ORs per capita, ASF ORs per capita, which may be driven by a number of factors, including the rate setting system itself. But if you haven't taken a look at it, I encourage you to look at the memo and the statistics that the staff at MHCC put together. Just a note in that we are seeing, much as we are seeing in the nursing home industry, considerable investor, I want to use that term broadly, not just private equity, but investor focused acquisitions in the state, and we'll be monitoring those operations. There's very limited quality information, however, as the research piece that you got shows that there's no mandatory reporting. One of the responsibilities of the commission is to launch an ambulatory surgery quality reporting initiative. That has been delayed for some time because there's no consensus-driven quality measures that have been widely accepted by the industry. That may be changing. CMS has a voluntary quality reporting initiative underway. Very few Maryland ASFs participate, but we'll be very focused on ASF because of the increasing role and importance that outpatient surgery plays in the delivery of healthcare services, and the changing nature, which historically has been, these are facilities owned by community-based physicians or larger single specialty practices, to this evolution where now we see investor-owned entry into the market. Oftentimes, these are done in collaboration with the practice. So you'll have a combination of ownership by an investor group or a large health system such as United Healthcare, keeping the physician operators as in ownership positions as well. But I think it's going to be an area of greater interest as it becomes more attractive. And in Maryland, because of the much lower rates that ASCs charge relative to hospital outpatient departments, it'll be something that payers are very interested in taking advantage of when it's appropriate for patients to seek care there. I'd also note that the span of what can be performed in ASFs has broadened quite a bit. Now it's relatively routine or major joint replacements to be done in ambulatory surgical facilities. In 2019, CMS allowed cardiovascular procedures to be performed as well. However, in Maryland, that's not permitted. We have 25 hospitals that perform emergency or emergency and non-emergency PCI. So it would have a significant impact if a significant number of ASFs sought that authority. None have to date. I also wanted to talk very briefly, just to give you a heads up. Normally this is at the end of the meeting, but Commissioner Boyle raised a question already on the recommendations for the nursing home acquisitions report that will be presented to you at the December meeting, which is on December 14th this year, because of the approximate date to Christmas would be the 21st, and probably wouldn't work. But the recommendations will focus, there are 9 of them right now. They'll focus on 3 will focus on pre-acquisitions, which are largely MHCC's role, and the other 6 will focus on either activities that we would undertake post-acquisition, such as monitoring of spending and alignment of budgets with actual expenditures, as well as work that OHCQ and perhaps the Office of the Attorney General can play a role in. Clearly, there's to the point that Commissioner Boyle raised, among the draft recommendations is one that would require OHCQ to take action on our recommended recommendations regarding licensure should an acquisition go through. I think it's important to emphasize that if we're going to take action to stop acquisitions, they have to occur before the actual closing date. Then it puts everyone in a bad position. The purchaser, the residents at the facility, and the state, because undoing an acquisition is not, for the faint of heart, and it would be much rather to take action before the closing date of the purchase, if at all possible. More to come on that. Also, in the December meeting, you'll also hear some recommendations on regulatory oversight of small assisted living centers. There's been a good deal of hand-wringing on this. It's a tough work group to convene. As those of you who've been around know, we don't have any really direct authority. We do have authority to collect data from assisted living, but we don't have regulatory responsibilities like OHCQ or, to a limited extent, the Department of Aging. We were drawn in because we gathered data more than anything else to do this. I think we have to broadly think about this in the context of senior housing generally, and you keep in mind that affordability for many seniors is challenging, and some of the smaller facilities really represent the only options they may have. So, our thought is that the oversight of small assisted living centers need to be blended with some sort of business development functions and information gathering functions, as well as what's typically thought of the role of state government, which is compliance with standards and surveys activities to confirm that operations are in compliance with state law. But I think, when you think about it broadly, we all know there's not enough senior housing, affordable senior housing in particular. And, these small facilities, how do they play a role without doing too much beyond the capabilities that may be present in the staff? So it's, I think an interesting study. It's not something that we necessarily have or seek regulatory oversight on, but the legislature told us to do it. And lastly, just want to bring to your attention that we will also bring recommendations on trauma funding to the commission in December. That's a core function of the commission, is to administer this trauma Physicians Fund. And the recommendations will focus on how to expand it. I'll stop there. I have a couple other things, but in lieu of the time and the need to move with the agenda, I'll hold that to the end of the meeting, let you know about those items. So thank you, Chair. Other questions?
Any other commissioners have questions? I have one that really doesn't have an answer at the moment, maybe I'm thinking about, but have we thought about as an agency, what our role, if any, with respect to AI or how that's going to impact what we do going forward is? Not that you're going to answer that today, but have we started thinking in the long term? Because I think over the very long term, for example, we all read articles about the downsides, right? You have to eliminate bias and stuff. On the upsides, you're also going to empower maybe solo practitioners with knowledge they didn't have before and able to do things before. It's going to affect the boundaries of the different practices and the organizations. I was just wondering if we started thinking about that, or if there are state initiatives
Well,
participating.
I think thinking and talking,
Yeah.
we're talking about it, and I think there's some experimentation on what the capabilities are. But in terms of a formal group, we haven't convened that, but we'll take that suggestion and talk about it. We have access to not only within the organization, but outside the organization, experts that may provide some insight.
I think it's too early to pop out with the sort of MHCC AI regulations, right? But that's not where I was going. But
Well,
maybe worth making sure we understand the impacts.
We're going to put those
Well,
together, Chairman, with our regulations on hospital at home.
Right.
And
Exactly.
performing cardiac surgery in the back of a pickup truck, you know.
But you know, the latter two, I have no comment on, but the former, the AI, because of course, a lot of the entities and organizations that we regulate are already deeply involved in deploying AI. and
I think
using it
that's-
in practices.
That's where
In
even
the hospitals.
if we're not direct, we may or may not be directly regulating AI at any point, but we would be aware when you talk about need and demand and capabilities of the people coming for licenses, those will be influenced by.
And I think that the, technology oversight we have along, the medical data bank, HIEs and so forth, I think this is a natural place to consider it across the, healthcare management in the state.
Great, thank you. And Jean Marie Gowell has a new staff member to introduce.
Come on up. I don't think we can hear the people on.
Oh, front and center.
Okay.
I've heard it.
Good afternoon, Commissioners. I have the pleasure of introducing to you Dr. Rachel Burvell, who has joined the Certificate Need team as a program manager and analyst. Rachel is the daughter of Ghanaian immigrants and grew up in the greater Seattle area. She attended Harvard University, where she concentrated in social and cognitive neuroscience and received a secondary degree in health policy and global health. Prior to medical school, she studied at Georgetown University and developed her interest in healthcare delivery and disparities research. At the University of Illinois Chicago College of Medicine, she was inducted into the Gold Humanism Honor Society. She is additionally a graduate of the Johns Hopkins Bloomberg School of Public Health. She is humbled to have received numerous honors, including the 2021 National Medical Association's Top Physicians Under 40 Award. And when she's not keeping herself occupied, she can be found tending to her plants and mothering her mini golden doodle, being a foodie and exploring new places with her loved ones. Please join me in welcoming Rachel.
Wow.
You're welcome. The agenda item number 3. This is an action item, the Baltimore Detox Center. The Baltimore Detox Center submitted a project change request after certificate of need approval for its project to establish a new drug treatment facility in Baltimore County. The project change will increase the capital costs associated with the project and make changes in the original physical plant design. The commission approved BDC's certificate of need to establish a 24-bed ICF in March 2020, and the executive director issued a first use approval in May 2023. Commission staff recently became aware of changes BDC made to the plant design the BDC failed to bring to the commission for approval. The executive director revoked first use approval and stayed the order, giving BDC an opportunity to present a project change request for consideration. The commission has the following options under this review. Approve the project changes and incorporate them into a modified CON. Approve the project changes in part or approve with conditions. Deny the proposed changes with explanation, or find that the proposed changes are of sufficient scope to warrant a complete review in accordance with the CON review process. Program Manager Maura Lawson will present the staff recommendation. Maura, please proceed.
Thank you, Chairman Sargent. Good afternoon, Commissioners. The request before the Commission today is for a project change after approval for an existing certificate of need for Baltimore Detox Center, or BDC, to increase total project costs and to make design changes to its approved 24-bed intermediate care facility, or ICF, in Baltimore County. On March 19, 2020, the Commission awarded the certificate of need to BDC, approving the renovation of a portion of an existing office building into a 5,944 square foot ICF. The facility would house 24 level 3.7 WM patients into 12 semi-private rooms. The total authorized project costs were $586,000, with $282,000 in capital costs. In July 2022, BDC submitted a project change increasing the capital cost to $970,000, having expended the funds without the required Commission approval. BDC claimed that the cost overrun was due to increased costs during the COVID pandemic and issues with contractors. The request was dismissed as untimely. In March 2023, BDC requested first use approval. And although BDC had not submitted the timely project change request, staff concluded that the conditions were deemed sufficient to grant first use approval. Staff was unaware at that time that BDC had made changes to the facility design, and first use was actually approved in May 2023. In July 2023, BDC provided notice to the Commission of its intent to convert 21 residential level 3.5 beds to level 3.7 beds. Only at this point did staff become aware that residential beds had been added to the facility. Staff were concerned that the original floor plan would not accommodate additional beds, which prompted a review. And Commission staff discovered that the project had been substantially modified without the knowledge or approval of the Commission. Additionally, BDC had repeatedly attested that there were no changes in the project on quarterly reports submitted throughout implementation and upon application for first use. Because the project does not conform with its CON, revocation of first use approval was issued with the stay of the revocation until November 17th. BDC was given the opportunity to submit a project change, which is the request being considered today. Should the Commission approve the project change request, BDC may submit a new request for first use approval. As mentioned by the Chairman, the Commission has the following options: to approve the modification, to approve the changes in part or approve with conditions, deny the proposed changes with explanation, or find that a new application in full must be presented to the Commission. So you can see the changes that were made in Appendix 5 of the report. The facility square footage has now increased from approximately 6,000 square feet to nearly 11,000 square feet. So they've taken over the entire building, not only that portion that was originally in the CON. The Commission originally approved a 12-room facility for 24 patients. The facility now has 13 rooms to serve the 24 patients, plus 15 residential patients. It was originally semi-private rooms. Now the facility has some rooms that have up to 5 beds in the room. The facility as it stands now does include additional toilets and showers to accommodate these additional patients. It has a large prep kitchen and dining room that were not in the original plan. Staff performed a site visit in September and confirmed that the updated floor plan matched the design of the facility as it stands today. Appendix 1 of the report shows the changes to the budget. They're seeking, BDC is seeking to increase the total cost by approximately $684,000. This was due to complications with contractors and unanticipated renovation costs not included in the original budget. BDC is paying for the increases in cash. Staff concluded that the increased cost will not impact the financial performance of the facility. So staff concluded that the project change is permissible as there are no material changes to the nature of the project, its location, or the core service capacities. The requested change would not alter the findings that the commission made in August 2020 concerning the need for and positive long-term impact of the project. Staff recommends that the commission finds that Baltimore Detox failed to comply with the terms and conditions of the March 2020 CON by making significant changes to its project without seeking without seeking commission approval. And that despite the BDC's non-compliance, that the commission approved Baltimore Detox Center's requested changes with the following conditions. Number one, that Baltimore Detox Center shall provide a minimum of 15% of patient days of care to indigent and gray area patients and submit annual reports of the level of this care to the commission for 5 years after approval. Number two, that Baltimore Detox Center shall address its non-compliance with the March 2020 CON should they or an affiliated entity seek approval from the commission for a future project. And number three, if Baltimore Detox Center seeks to add additional intermediate care beds to its facility, it shall provide the commission with evidence that it has appropriate staffing levels and bed and bathroom configurations that afford patient privacy and safety. Attending in person for Baltimore Detox Center today are Casey Bright, the Chief Executive Officer of Amadeus Health, Aaron Keibel, VP of Operations Maryland for Amadeus Health, and Darcy Smith, counsel to the applicant. And virtually, they're attending virtually on the phone from Amadeus Health are Baruch Raban, Chief Investment Officer for Amadeus Health, and Daniel Schick, in-house counsel for Amadeus Health. Thank you very much, and take questions.
Could you say, I'll throw the floor for questions, but could you say why did they say this happened?
I believe that the explanation that we were given was a change in staff that caused some confusion in the reporting responsibility.
I have more questions, but does anybody, the commissioner, have questions or comments? I see a hand from Commissioner Boyle.
Yeah.
Oh, I'm sorry. You go, Commissioner Boyle. I'm sorry, I heard somebody else. We'll give you a chance next.
Okay. Okay. Thank you. Well, I've got several questions, but I guess my main question is the approved project included 12 semi-private rooms. And since the approval, they've added quad rooms, 2 triple rooms, 4 quad rooms, 1 room with 5 beds or more. That's not what we approved. I'm having a hard time on why we have such, we're trying to go to semi-private and private rooms in most cases in many different types of facilities. Why are we, why is it suggested that we approve something with these rooms that weren't even, originally approved?
I guess my answer to that is that there is nothing currently in the regulations that totally forbid it. And that there is, well, I'm gonna talk to Caitlin here, right, or ask Caitlin right now.
Yeah, I think the commission had concerns that the project was presented as semi-private rooms, and that's what they approved. The amount of licensed beds hasn't changed. And that couldn't come before you today as a permissible modification. So the amount of beds approved is the same. I think we've talked about this before, that there was a legislative change that after a CON approval, ICFs can expand the amount of 3.7 beds as much as they want without our approval. So I think because of that disconnect, you know, we can approve this project today and they can seek, you know, they can give us notice in a few months that they want to add as many beds as they're permitted to under the licensing authority. And so I think the staff felt comfortable putting the condition on saying, if you want to expand the 3.7 capacity, which I think is their intent eventually, they have to come back to us and explain to us what is the bedroom configuration. And at that point, staff can review how many beds are in the room and discuss whether or not the commission thinks that that is sufficient for patient safety and respect.
Well, I mean, I personally don't feel that, you know, a room with 5 beds or even 4 beds is good for patient safety.
I do understand the concern, and I think that most of the guidelines when it comes to these things are addressing facilities that have patients there for a longer time period. And one of, you know, patients in who are going through detox are there for a very short period of time. And so there's less regulation on numbers of people per room in these types of facilities. I'm not saying that I agree with that, but that's where it stands right now.
Did you get any advice?
Go ahead, go ahead.
I think,
Did you ever get any advice from BHA on this matter? The Behavioral Health Administration, which handles licensure of these types of facilities.
My understanding is that they don't have any regulations concerning how many beds are in a room. They had suggested looking at a joint commission or the other companies that do the accreditation. And we will say that with this, these configurations, with having the 24 ICF beds and then I think the 19 or 20 3.5 beds has all been approved by both the licensing agency, BHA, and the Joint Commission. So they did submit accurate information to those two entities.
And they're very well aware of the configurations.
I believe Commissioner Blake had a question.
My question has been answered.
Okay. Go ahead, Commissioner Jensen.
I've got a couple of questions. One, in the original application, was there an interested party or any opposition?
Yes, there was.
No.
Okay, oh, they withdrew.
There was an interested party and a reviewer was appointed, but then the interested party removed their interested party status. They're interested in an interested party.
Right.
So it ended up being a staff recommendation.
Was there, then was it related to that then? Do you have any data on bed availability needs for these beds?
So the staff did not do a new need assessment. They did take into consideration the tables that Baltimore Detox submitted, which was that they are routinely filled within their 24/7 beds, and that their projections is that they would have 95% occupancy moving forward.
And do you have any sense that the failure to notify us, I mean, is that was that intentional or was it a mistake? Is it something that's likely to happen again, or is it something that's not likely to happen again?
I would hate to answer myself for anyone else's intention or.
Well, perhaps we have representatives
We do
here,
have
right?
representatives here and.
But I do want to know what your sense of it is. I mean, are we dealing with an organization that is flouting the authority of the commission or somebody who made a mistake?
I think what they have represented was that this was an oversight and that it was in the middle of COVID. The CON was approved in March of 2020, and that there was some pretty drastic staff changes. And you can kind of see that they came forward with these very different budgets because new staff that came in and identified a lot of areas that they didn't originally identify that they would need to spend different costs. So I think the staff believes that this was not an intentional, one over, especially because they were permissible modifications. They would have likely been approved. So there was no real reason to try to not be upfront with the commission. And you'll notice in the 3 conditions, the second one is that if they come before us again to submit a project, they need to be prepared to talk about this again as to why they did not comply with the CON.
What process do they have in place so that this won't happen again, based on the staffing change for improvement?
If it's okay with you, can we?
Should we move over and let them sit here?
You guys.
Darcy Smith and Gordon Weinblatt representing the client.
Casey Bryant, Chief Executive Officer of Ambulance. Eric Dibbles, Regional Vice President.
So do you want to speak to
Yeah.
the process?
Yeah, so previously, this was a company that is, first of all, MNS Health is a management service company. So Baltimore Detox is a entity that we manage and oversee. Previous to me coming on board, which I came on board as Chief Executive Officer in September of last year, the ownership of the company managed this project. So it was not managed by the staffing of the MSA. That has changed. And as CEO, I oversee now those types of projects. And we've had some changes in regards to how our company is managed. So the changes in titles, so that it was a founder, CEO, ownership previously. So, you're doing both roles. And so I was brought in to separate that. And then, of course, Aaron, who serves as our VP of operations, he serves as basically the CEO of all of the Maryland entities. So Awakenings, BDC, Foundations, and Funkstown. Yep.
So something I want to highlight is that this is not a new company, or that this type of process is not new to them. They just had some folks in those positions that did not pass on that information to the next people who took over the staffing positions. I am your second or third attorney on this, and I alone worked with at least 3 different people as my direct contact. And this team seems to be has prior experience with CONs, has prior experience with other similar facilities, and I have every faith that they are on top of it now and have processes in place to make sure that they're reporting as properly.
Just for clarity, when you say not new, it's not new.
Oh, sorry. They have a lot of different facilities in Maryland and in other states that they manage. So this is, operating these types of facilities and complying with CONs is not a new process for them.
5-10 years.
Can you speak to that,
As far as
of Amatus?
Oh, Amatus has been around for 6 years. Yeah.
But you're managing this project, right?
Now, yes.
Okay, so your answer actually raises more concerns for me. There's been a bunch of turnover and you're the manager, so you could turn over as well, right? You have a management contract that could turn over.
Of course.
What processes or procedures are in place so that we don't have the same problem again if there's a turnover, if you're not sitting here next time?
Multiple levels that have been added to that. So when I was speaking to that ownership group, so the MSA, they literally have the MSA from an ownership standpoint and serve in those roles.
MSA is what, master service agreement?
Yes. Yeah. So we just are managed, or an MSO in some of the healthcare. We're more like an
Contract
MSO.
by which you manage the project.
That's right. Yes, sir. So ultimately, that was it. It was them, and the company grew very fast. It went to 9 states, multiple treatment centers in 9 states over a 4-year period, which is, aggressive growth and rapid growth. And that infrastructure did not exist. And so his position, as well as my position, being separate from ownership would be, and we also have 2 other VPs of operation. We have EDs that are below those VPs of operation now, directors of operation that are below those EDs. So when you look at like a BDC project, there are now 6 or 7 individuals that are in place in a structure that are managing and overseeing that project and have interest in it. Previously, there would have been one person assigned from the facility, and then the ownership group.
But they all work for you, right?
They do now, yes, sir.
Right, so if there's turnover and you're no longer managing it, then they'll all be gone, right?
Oh, well, no, they're separate entities. So those individuals at the different varying levels work for the different entities. So as an example, Aaron, who has an executive director at Sunrise, that is the senior officer of that entity. He is only a part of the MSA that's managing that. So that executive director would not necessarily go.
So they work for the owner.
They work for the owner. That's correct, sir.
Okay, so how far down that chain that you described do we go before we get to people who work for the owner?
It would be at that ED level. So there would be a VP of operations, there's a director of compliance, and then the chief executive officer.
Yeah, I'm confused. So you're the CEO.
Might need a
You
flashlight.
work for the management company.
Correct.
Next level down is what?
It would be the VP of operations.
And he works for the management
That's
company.
correct.
Next level down is what?
Executive director,
And they work for?
the entity.
Okay, so the answer then to the question, I suppose, would be then, is there some process in place where the executive directors know that they've got to comply with these things?
So that's this process, getting it cleaned up, and then they will take that over. So from an MSA standpoint, I can even give you a bigger example. There were 300 employees as part of the MSA when I started. There are 13 employees of the MSA now. The operation has been shifted to the site and is no longer managed from a single site. That was the problem with growth. We were managing 9 different states from one state, one single location, and that rapid growth. And these are residential detox, medication-assisted treatment programs, outpatient, housing. And so ultimately, without that infrastructure on the ground, that's why you saw that turnover. If there was a change of partnership or whatever, it was all managed from the MSA. It should have been managed from the entity level because that is an entity request. The CON is an entity request and not an MSA request. So the responsibility should be and will be placed within that executive director. I think it's the responsibility of the MSA with the legacy knowledge to correct this problem and then safely place it back into the hands of the entity now that it has structure and organization. I think another reason is that the CON process for them, I believe, began 3 to 4 years ago. So there was no staff within the entity to generate any revenue to manage that project until we opened in May.
Oh, it's getting very hot today, yeah.
Someone on the line, I think, has some open mic.
Enjoy it. Thank you. You're welcome.
Please go ahead. It happens.
Oh, yeah, I'm sorry. So ultimately, that is the goal and the desire would be for the entity itself to be able to manage this project. It's just that did not exist previously. And so I believe that a local attention and somebody who is living and breathing it every day will have better understanding of managing the project.
And part of these regulations, we don't create organizations to serve regulations. We create organizations to serve people.
Yes.
And showing that you can competently manage the regulatory administration of a healthcare entity is a good proxy for the fact that you can appropriately manage the healthcare needs of the population. And so if y'all didn't quite know what was going on with the regulatory side of things, that's all we get to see here. It does raise a bit of a red flag from a patient safety standpoint of where patient safety and patient care issues falling through the cracks as well. So, I mean, that does raise some concern. And what would be your response to that? What assurances or what structural changes have you made to not only heighten your regulatory compliance with this organization, but also maintain high standards of care, quality of care, and compliance with standards of care for your clients?
So I would answer that with, in this process, I would tell you that confusion in regards to this regulatory body, we communicated with BHA the entire time. BHA worked with us on, we're going to move foundations into here. The residential piece stays here when Rutherford, so they were a part of that process. When I came in, the only thing I was told was that after 90 days, you could expand your medical detox beds. That was basically what was given to me. So when I went through that process with BHA, there was a communication, and I thought things were communicating within the government entities until I put in that request to Darcy. So just so that the commission's aware as well, we put in the request for the 45 beds, like we put it in, like we requested it because I thought that was the right thing to do with the commission. And so this kind of got, which, I mean, I'm obviously glad that it came up to so we could address it appropriately, but I did not realize that there was not communication between those two government entities, and that would have been my fault, because in no other state would we request a CON and go through the licensing in a separate entity and then it be completely managed separately with separate regulations. And so that was my fault. And because of the turnover, we didn't have anybody else that was managing that project previous to me coming on. So that was, I mean, that's our problem, obviously.
Welcome to Maryland.
Yes. So it was, and just so that you guys are aware, I've been a CARF surveyor for 21 years. I'd be the senior CARF surveyor in the state of Maryland. I've surveyed 175.
What does that mean?
So what that means is that this is what my job is: regulatory conformance and management from a national level. So I go into other behavioral health centers and give them their national accreditation. And so I completely 100% respect and understand the premise and the process. But I was not aware that that existed until I put in the request to extend the capacity of the beds. And so that was a surprise to me. I got educated really quickly. And I can tell you guys that, under my leadership, that will not be a problem. And I have no intention of leaving. I have been with the company outside of the MSA for 4 years. So I've been here. Previous to that, I was the CEO of a company, a behavioral health company that was about $100 million, similar to Amadeus, for 13 years. So I don't move and I don't intend on moving, but obviously there is an ability and a way that ownership could make a change. So I can't promise you that. But what I can tell you is that I've been consistent in my career and intend on continuing to be consistent, and believe that the intent of the ownership is to do that as well.
If I can highlight a couple of things that Casey said, just to answer your question, Commissioner. They were in constant communication with the licensing body. The licensing body was aware of the changes, did a site visit to approve their license. And they are also accredited by the Joint Commission, which is one of the top accreditation entities of these types of facilities. And that entity reviews their policies and procedures and has certain standards in place that they had to meet in order to receive that accreditation.
And that happened in July of this year, just so that the commission's aware. It's a 3-year process usually, and our last survey was in July of this year.
I think I saw Commissioner Blake. Did you have your hand up?
I did, and some of the questions that I had earlier have been answered. My last question is really for clarity for me. So the need for change, or the request for change, is because of new management, or is it because that there is an actual need to serve and improve this population?
So are you speaking to this specific project change, or the idea that we would
The project change, yes.
Okay, so the project change is being requested because of things that already occurred. The cost of the facility build out increased. They did end up taking over the entire facility, but the number of beds at issue did not change for the level 3.7. So the need expressed in the original CON application is the same need that was relied upon for the build out.
I understand that, Mark, correct me, is part of the CON application is what is the facility being built, and we analyze whether that's cost effective or likely, under metrics of cost versus. And instead, a different facility was built, is not the one that we approved, and that's why we're here to decide whether to extend the first use by amending the CON for the facility that was built. And if we don't do that, the facility can't operate.
Well, they can operate at a 3.5 level, but just not for the 3.7 detox.
If I can go back, if I understand Commissioner Blake's question properly, I mean, well, it prompted a question for me, and that was just sort of directly. Is it being changed because of need, and we didn't hear about it because there was a management change, or is there being a change? Is a change requested just because there's a management change and there's some financial issue.
So
Thank you. Thank you.
That close, Commissioner Blake?
Very much so. Thank you.
I think this is a question that the commission asked and wanted to know, which was, at what point did the project change? And I think that's what you're all getting at, and I'll let Baltimore Detox respond to that. But the last CON modification was March 2020, and that's at 24 ICF beds.
Well, that's not, trying to get somebody here to tell us that the change was because there's an actual need for the beds that were actually built out. That's,
I think
I'm giving the answer to the question.
I think the answer is though, it's not need. The same number of beds were built, but if somebody said I will build a 2-story facility with 24 beds and instead build a 24-story with 24 beds, you would say, well, the need is the same, but why is that a palace? Because that wasn't what was our analysis of the financial condition. I'm not saying that's what happened, but so I think the reason we're coming.
Maybe I
to that-
misunderstand it, because that's not the way this part of project changes doesn't look like that to me.
So the changes that Baltimore Detox did that we are reviewing, even though they've already done them, is the change in the project budget and the change in the plant design. They did add 3.5 beds, but this commission does not regulate those beds.
Right.
So that might be where the confusion is, and if you Shirley answered, do they need those 3.5 beds and when did they decide they wanted them? But that's not something that this commission regulates.
Okay, and how about the 12 semi-private rooms, now 13 bedrooms, total 39 beds? I mean, those, I'm just looking at the squares and they're different. We don't regulate that either.
We regulate the 3.7 beds. And so the 3.5 and the 3.7 beds from our site visit are spread out among those 13 bedrooms, depending on who they have walking in those days. Is that correct?
So there's more beds in the facility, but there's the same number of 3.7 beds as was initially approved.
Right.
Is that correct?
We added more beds that we don't regulate.
And we don't
Right, they
regulate.
added them, and normally we
And-
are not told when 3.5 beds, if they add 3.5 beds. The only thing that we got concerned about is when they said they were gonna be converting these beds, and we didn't know that the facility had changed. All of a sudden, it's like, where are they putting these people in the 12 rooms that we approved? Because we only thought they had a 6,000 square foot facility with no room for more beds.
Did the original approval include the provision of a minimum of 15% of patient days of care to injured?
Yes.
So that's nothing new.
That's right.
Well, let me ask you a different question. Of the 3 recommendations, right?
Right?
Are any of them new?
The last 2 are new.
And then, so the last one, Baltimore Detox Center shall address its non-compliance. What does that mean? They're addressing it now, right? They're telling us what happened. So what would they do in addition to that?
I think that when you apply for a new CON, one of the criteria was, have you complied with previous CONs that you received? And they're going to have to address that issue because it was a non-compliance.
And the commission has the authority to take that into consideration on a new project, which is very different than what's sitting here now, which is a built-out building, the services already being provided.
Commissioner Blake, I just want to make sure, did you get an answer to, make sure you got an answer to your question?
Yes, thank
Okay.
you.
Are there any other commissioners with questions?
So the follow-up on my first question, originally we approved how many 3.7 beds? 12? 24. And those were in semi-private configuration. Okay, and now there's additional beds in the facility that are 3.5 beds, plus the original 24, 3.7 beds. And now the facility includes 3, 4, and 5 person rooms, which originally it didn't. Is that accurate? Okay.
There are some
There are some
there
semi-private.
are, but not, I don't know.
You
if
approved
there's 12.
semi-privates
That's
originally.
correct. Yes.
We did not. So that's a bit of a change. But as you said earlier, we have no regulatory authority over that, nor is there any standard of occupancy rates like we might be thinking of in long-term care settings. Okay, thank you.
Is that, I was going to follow up on that same thing. Is that what we're saying is for the rooms that have 5 beds in them? Whether we like them or not, we don't have the authority to do anything about it because that's not the question before us. Or am I supposed to be making a determination of some sense of here about whether having those 5 beds meets some quality standard that we're applying? I wasn't clear on what my decision is.
Chairman, can I ask you a question? This is Commissioner Mandari. Who has the authority for those beds? Who approves those one, if not the commission? Do we know?
Approve the 3.5.
Yep, additional room, additional bed. Who approves that? You said commission has no authority about that.
DHA licenses them.
EHA will license the 3.5 beds, did license the 3.5 beds.
Thank you.
So to
I'm
answer-
interested in the chair's question.
I think our council's about the council list.
So I think that the standard that the commission normally looks at when they're looking at how many beds are in a room is in the state health plan. And it reads that an applicant must demonstrate its capacity to admit and treat alcohol and drug abusers requiring subacute detoxification by documenting appropriate admission standards, treatment protocols, staffing standards, and physical plant configurations. So it's a kind of broad standard. And then we often look at the BHA regulations to see to make sure that they're compliant with that. So, you know, I think that the commission does take into consideration how many beds are in a room when, you know, they first come in. But like we said, because of this kind of disconnect with the legislation, as he said, we can approve beds and then they can go and expand them. So they can go and add a lot more beds into their rooms after our approval. So kind of the degree in which we weigh how many beds you're putting in a room now, when we know they can change that as soon as we stamp the approval, is something that the commission kind of has to consider. So in this instance, I think the staff reviewed, you know, that BHA did approve them, the licensing agency and the Joint Commission, and that if they want to expand any more of the 24 beds, they actually have to come back to us and prove that, you know, they do have enough room to do that, both within the bedrooms and the bathrooms.
I mean, I sort of see what you're saying, but if somebody filed and said, I want 24 beds in one room, we wouldn't really say, that's fine, because if we give you 1 bed in one room, we know the next day you could put 23 more beds in there, we're fine. Where do we draw that line?
So I do think there are some other regulations that the facilities do have to follow. I think, I don't know if you know, Darcy, I think is it 1 patient per 70 square feet? Is that within the Joint Commission?
Yeah, it's in Comar. It's like the 1 to 40, 1 to 45, and then if there's 1, it has to be 70 square feet. If there's 2 people in the room, it has to be 45 or 50 square feet per person. So it gets to like 100 square feet if it's, but that's the standard.
And yeah, and may I add something? I think you already said it, the Comar regulations for the licensing do have requirements of semi-private rooms for different levels of care, but not the levels of care that we're talking about here. So, you know, the BHA has considered that type of standard before and has not made that type of standard for this level of care.
So I guess one question just for the commission it might help is just to ask it as this: why should I not be concerned? Because if it were a continuing care retirement community and somebody's like, I want to have a 5-bedroom thing, you think, oh yeah, that's not happening, right? I don't know, this is a completely different area. So could we just answer the question, why is it safe or good practice or justified to put the five beds in the room just for the commissioners in this context for this type of facility?
You want me to answer it?
Yes, please. Well, I guess anybody can, but
Yeah,
you
yeah.
seem
So
to
I'm
be
happy
ready.
to. I just didn't want to jump on it and then somebody else speak. So it is, I mean, that is a traditional thing on the residential. One of the reasons that I put in the request to change the number of beds and get rid of the 3.7 is that this 3.7, 3.5 mix is difficult. So you have one population that stays 5 to 7, days in that level of care, and the next one staying, 30 days as an example. So from a quality of care standpoint, your residential clients are very active. They're staying active. They're not allowed in their rooms during the day. The only reason they're allowed in the rooms during the day is if they're sick. They also have a television, in some cases, 2 televisions in their room. They also have an entire downstairs where they have a day room, a kitchen, and they also have meditation rooms and separate rooms and group rooms. So in one way, we could have configured in a way to spread that space out and give everybody all their individual space from a bedroom standpoint, but they're only going to spend the 8 hours or 9 hours that they're sleeping, showering, stuff in there. For us, and that's what makes it a little bit hard not being in the facility and describing it, you want that space because a majority of their time is spent on that first floor in that space. So if you look at it, that the whole building, you would have tons of square footage, and definitely we could have reconfigured it to say you have males upstairs, females downstairs, and here's the separation, and you could have had that. And it wouldn't have hurt us from a clinical treatment standpoint, delivery standpoint. It's just the reality is that the clients do not spend much time in their rooms. And we have facilities that are like that. And I can tell you, if we had the choice, we would change those again, because the complaint in some of our facilities in Ohio is they do not have enough recreation space throughout the day. It's a lot of isolated alone time. Substance abuse specifically is a social disease in a sense that you're deterring the rest of society from interacting with you and participating at the same level as you, because you're obviously using drugs and cognitively you're not connecting. So we don't want them in that isolated space. Whereas if I had a patient who was, on dialysis or having some sort of procedure, I definitely want that privacy and that quiet for that reason. And so the diversity of rooms, I think, allow us to provide a better level of care based on the different people. And that would be my answer for it, because you can definitely reconfigure that building and take the 10,000 square feet and say, now I got patient care on 2 levels, or you can say, this is your living area, this is where you sleep, and then downstairs where you spend the majority of your time, especially awake, here's access to that. So.
Are there any other commissioners who have questions?
One last question. For the 3 conditions, what happens? We talk a lot about long-term care facilities. I know, different business, but they get bought and sold all the time. And so if this facility, which is a for-profit company, which appears to be profitable because they're doing all this with cash, gets sold, then, new management team, new everything. Do we have any legacy responsibility or concerns after, different ownership takes over? That's my question here. If they're like, man, we're tired of dealing with this commission, we're gonna create a new business, we're gonna sell it to our new business, and now now it's owned by a different business. So all this slate is wiped clean because now we're a different business. I mean, is that a risk that we see? Is that something that would happen? Do we have enough level of concern to tie down our concerns to the next owner?
We haven't encountered that particular situation, but I would think it would be still a requirement that they provide notice to us of sale. And that's kind of the way that the commission's more direct involvement in nursing home acquisitions got established, as we saw the peculiarities of that with ICF. And we use that as really the only service that's directed by 7 ASAM inpatient treatment. I still think they would have to provide us with a notice of sale. Whether I can't predict that, how we would react. We've never encountered one, as far as I know.
Right, I can't remember one. And any new owner, if they wanted to add beds or make, that kind of change, would have to at least notify us. And at which point, believe me, this is on our radar to say, where the heck are they putting more people?
As a practical matter, the due diligence for the acquisition would turn this up. So the buyer would be aware of it, and the buyer would do their own analysis of the law and determine whether or not they had to contact us, and if so, what they had to do. And then depending on the kind of people there are, they might say, even if we don't have to, we want to do that because we live in this state and it's a regulated state, so best not to get sideways with the regulators. Or if they're a different kind of people, they might say, I would rather get forgiveness and permission, so carry on. But they would certainly know about it.
Thank you. Any of the commissioners on the line have any questions? That, I will call the question. Can I get a motion? Hold on, let me read it. Can I get a motion to approve with conditions Baltimore Detox Center's request for project change?
So moved.
Commissioner Jensen, thank you. Can I get a second?
Second.
Commissioner Buzinski, thank you. Is there any additional discussion or any additional questions? Okay, all in favor?
Aye.
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 Are there any opposed? If you have your modification.
Thank you guys very much.
Yep, thank you.
Appreciate it.
I appreciate
And,
that.
Go ahead, Commissioner Jensen. I was gonna ask Maura something before she escaped, so.
Go ahead.
Okay.
Go ahead, Commissioner Jensen.
I was just gonna say, I voted in approval and I wish you, Godspeed and good luck and success. And hopefully we don't have this situation again.
100%.
We
Thank
appreciate
you,
your
guys.
time and consideration.
Thank you.
You're doing good work, so hopefully, the community is gonna benefit
Great
from
need
that.
for this work in our state and across the communities. So thank you.
We appreciate it. Thank you guys very much. And please come visit us. Reach out and let us know if you want to come see the facility. We'd love to. have
Hopefully
you.
not in need of detox.
That's right.
But go visit.
I had one comment. I had one comment on the standard, and it doesn't relate to this one CON, but maybe to the next one where I get the point where someone who applies and they can increase the beds the day after it. We can't look at quality the same way, but I think we probably need to refine our approach. Is it just, well, BHA is licensing that, we're relying on BHA, that could be an approach. Or is it, well, we don't want to entirely rely on them, these are our other standards. But I feel like some clarification that either somebody comes in and they apply that either meet our quality standard, we don't have a quality standard, or they don't meet our quality standard would be like a very clear answer for us, because I'm not clear exactly what to do with, we don't love it, we can't exactly, we don't know. Like, I feel like we should, as a, maybe some, as a project, look at how do we refine that so that we can tee it up.
Well, I think let's go back to the priority for state health plan chapters that need updating, and this is on the priority
Right.
list. I think that this particular application has revealed, like, one of the things that we've been struggling with, and that is they changed the law, the statute in 2019 to allow existing facilities. If you have gotten your CON approval, you can add beds with simply a notice to the commission. So here for this case as an example, we go through a lot of time and effort to look at the configuration, the ratio to bathrooms, how many people in a room, and then they get the CON and we get a notice and they're adding all of these beds and we have no control. So it's kind of this, it's an interesting, on the one hand, when 2018, when the commission tried to get out of the business of regulating these types of facilities, they said, no, we want your oversight. But then they changed the law to allow the existings to add the beds. So there's a big gaping loophole. And I think that they need to understand how this is impacting. I mean, it's almost pointless for us to go through this exercise,
Well,
only to have.
I think that was what I was getting at. If the answer after analysis is BHA licensed them and they look at those things, then I think that could be a commission position. I'm not saying that it should be, and other commissioners may disagree. But I think we should look at how do we refine that so that, because I sympathize with Morris. They're like, we don't like it, we don't feel that we can stop it. Like, it's like, either we clearly can't stop it because we don't have the authority and we should back off, or we should do something about it because we do have the authority and we want to exercise it, but it's sort of this gray area.
Well, I've had a conversation with behavioral health to that end, and I think we're going to try to collaborate and figure out together how can we collaborate and fix this, because it needs fixed.
So Marcy, from a practitioner's perspective, thoughts?
It's just like I am representing a client here.
Yeah, I'm gonna think on that, but I.
No crime, so no.
Civil.
But you can pass if you want to.
So I want to just tie this together. So 2018, the commission, after meeting with the industry once, worked with the chair of HGO to introduce legislation that would deregulate from CON 3.7 ASA facilities. We thought that the industry was generally supportive of that. There was several leading organizations, including Father Martin Ashley, who now goes by Ashley, who said they were very much in support of that. At the bill hearing, however, all the facilities that it previously had said we would support such an action came out and opposed it. The sponsor, which happened to be the chair of HEO, said, using a term, work it out, but I'm going to put this in the drawer this session. She didn't. The House never voted on it. It was not interested in the Senate. But her view was that more work needed to be done. She didn't out and out reject it, but no action was taken on the bill. It was not voted on. The next year, as part of the CON work group, this particular provision was paired with another, what on the face of it seems similar, which is our authority over the hospices established in the state, in which there we gave the ability of any established general hospice to establish an inpatient hospice without going through CON. In parallel to that, these two were kind of coupled together, or the way we presented to the commission, as well as the legislature, was that we would give existing 3.7 facilities already operating in the state the ability to expand existing facilities without additional CON, which on the face of it, we thought this is parallel to what the hospices had suggested would work for them. But the market or the environment is much, much different. The market for hospice services is pretty static, pretty stable. There's about 15 or 16 hospices that operate in the state, and they've been operating in the state for quite some time. There's a bit of, again, acquisition going on currently, but not like the market velocity you see in drug treatment, which there's incredible demand, incentives placed to establish facilities. And I think it was ill-timed, if nothing else, to have done this at the time, but it seemed, with good intention, with support of the commission, with the support of the legislature, it was passed. So we have this regulatory regime, which is kind of a half regulatory regime. You come in, get your first certification, and then you can do whatever you pretty much want in that building going forward. If you want to build another facility, again, back to the CON process, but if you want to do anything else. So I think Casey, it was kind of a tell. He said, we're going to come back quickly to do, I read it as to do what we really wanted to do, but they didn't forget they kind of neglected the intermediate steps of making these modifications as the project reached maturity. And I think it is a serious situation when people don't conform to the CON provisions. Otherwise, why go through the process at all? So we have relatively limited authority, but it's really anchored in, I think, a flawed corrective legislative action that occurred in 2019.
It's not necessarily harmful if the licensing agency that comes back every year is looking at that same question. So it's maybe, is there a gap? I don't personally feel that CON has to address that question. I do think probably that needs to be addressed, right? Somebody has to set a standard and enforce it.
Right.
Whether it's us or BHA, I'm less personally, more agnostic about. Somebody needs to be the expert and say 5 is okay, or 5 is too many, or, something like that. That way.
So what you're saying, we'd get the certificate of need to get approved, then from that point forward, they would, BHA would be looking at to make sure any further changes. Yes.
Right.
I'm saying, yes, I understand.
Yes. Yes, that's one option. There's many ways to do it. My point is we should work on figuring out the way to do it. Just when we come to these, I'd like I'd like folks to apply to us to know what standards we're going to apply. We would like to know what standards we're supposed to apply when we're deciding, so.
When do we stop applying standards?
Oh, right.
Thank you.
Thank you very much. Agenda item number 5, the 2024 MCDB data submission. The Maryland Healthcare Commission is required under COMAR 102506 to publish the medical care database. Did I skip an agenda item? Oh, you're right, I apologize.
Yeah, we actually have.
We're back up to agenda item number 4. Sorry about that. Mandated health insurances evaluation, annual behavioral health wellness visit. Insurance Article 1501 requires that the Maryland Healthcare Commission, MACC, annually assess the medical, social, and financial impact of proposed mandated health insurance services that failed to pass during the preceding legislative session or as requested by a legislator or legislative committee by July 1 of each year. MACC staff received a formal request from the Senate Finance Committee to evaluate Senate Bill 108, introduced during the 23 session of the Maryland General Assembly, but failed to pass. MACC staff contracted with Axine Health Partners, an actuarial consulting firm, to evaluate Senate Bill 108, which would have required health insurance carriers to provide coverage and to reimburse for an annual behavioral health wellness visit on the same basis and at the same rate as an annual wellness visit for somatic health. Greg Fenn, a consulting actuary with Axine Health Partners, will present the findings of the study before asking the commission to approve the report. There you go, Greg, you have the floor.
All right, thank you. And I have a slide presentation. Should I share my screen or will that be pulled up in the room there?
I think we are seeing your slide presentation and just tell us to advance the slides. I think that's probably the best.
Okay, perfect. Well, thank you, everybody. As mentioned, I'm Greg Fenn with Axine Health Partners. Axine Health Partners is a consulting firm that's focused at the intersection of actuarial science and medical care. And I won't name them, but I had the assistance of 3 other actuaries and our medical director assisting on this project. I will call out Joan Barrett, who is going to present the financial implications of our study midway through this presentation. As mentioned, this was a requirement of the Maryland Healthcare Commission after a bill didn't pass regarding the coverage of annual behavioral wellness visits. So next slide. So that's really the legislative background. And the idea of the bill was really to treat behavioral health wellness visits the same way as somatic wellness visits. A wellness visit, really, from a layperson's term, this is really a checkup, really a session where a patient can meet with a psychiatrist or behavioral health expert without really any symptoms present, or to really discuss how things are going and what may be needed from a behavioral health standpoint. The bill included no cost sharing, which is presumed to make access more financially attractive, and also to really incent coverage without there being a financial barrier. The bill did not pass, and that's when we became involved. Next slide. So currently there's a mental health crisis in the United States, which is only getting worse. A solution that's really been popular over the last 20 years is what's called integrating behavioral health care with primary care. Some people think of that as really caring for the whole person, and really prioritizing the care of behavioral health on par with medical care, which has not been historically the case. To put some numbers around this, the suicide rate, you can see, increased from 10.7 per 100,000 people to 14.2 in 20 years, from 2001 to 2021. It was generally pretty flat up until 2001, and then has increased a little bit more of a bump during 2021 with the pandemic. Depression in particular rose 28% during the pandemic. We learned, if we didn't already know, that social isolation is a major problem that creates the manifestation of mental health conditions, and the Surgeon General and others have written significantly about that. Looking at some of the barriers, the first is really recognizing the existence of a problem. Unlike medical conditions which sort of manifest themselves in uncomfortable symptoms. There may be behavioral health issues which are not necessarily known by the patient. And there's also stigma with communities, and in particular with children and teenagers that may really not understand their situation and may feel uncomfortable communicating that to their parents or other adults. And the one that we've really focused on was really the intent of the legislation is the financial barrier, which is not only cost sharing, but gaps within health insurance coverage, and making it trouble to see a provider from a financial standpoint. And then provider access, a lot of geographic areas where behavioral health providers just aren't available in the need that they should be. Solutions, we really kind of see this as two. There is this integration with primary care, and we'll talk a little bit about some of the carrier surveys that we looked at, where I know at least one really preferred that over sort of the separate behavioral wellness visits. And then what we focused on was encouraging the behavioral wellness visit through the removal of cost sharing. The financial impact that's expected, a slight increase in the first year, and then really negligible later on. And the non-financial concerns are really the implementation of this, the clarity around the benefits and the coding and all the administrative things that go with that. Next slide. So about the clinical health visit, wellness visits can be conducted in person or online. Online telehealth has really become more popular. During COVID-19, it got up to 50-60% during COVID. It sort of leveled off in 2022, around 30% of behavioral health visits are conducted through a telehealth modality. And what happens during the visit? What are the key components? The first is really assessment, which is much like a medical visit, is really gathering information on the patient, understanding what's going on with them in their home life, in their social lives. Diagnosis and treatment, something that may or may not happen. There may be treatment. Generally, the provider's really trying to understand the diagnosis, and it could lead to a referral, could lead to a follow-up, could lead to treatment there. And then prevention and health promotion, often that's specific to the patient, depending on what their lifestyle is, what their particular needs are. And there's an abundant amount of resources, pamphlets, videos, which I think have grown significantly since COVID and mental health, behavioral health becoming more of a focus. The screening recommendations of what's really considered preventive care, effectively all situations that you might consider behavioral health don't fall under this. For example, an eating disorder is not specifically delineated as something that would be a preventive screening. The three that really are counted here are anxiety, depression, and substance abuse. So with that, I'm going to turn it over to Joan on our next slide to kind of go through the financial analysis that we did.
Thank you, Greg, and hello, everyone. We did our financial analysis in two steps. The first step is just to see where we are today without the legislation. To come up with those numbers, we used a combination of proprietary and published information and found that behavioral health visits account for approximately 0.2% of total costs currently. Next slide. Next slide. Okay. So what do we expect to change with legislation? Well, first of all, we expect more people to receive care. If they're getting more people will be getting behavioral health visits, and they will be getting more care as a result. We assumed a 2% increase per year. That will be offset by savings. We know that if some illnesses, mental illnesses are found early, they don't become worse ones. And probably more importantly, that people, especially people with depression, who get their mental health treatment will take their drugs for chronic conditions more. So we expect some savings. We do expect a burst of savings the first year because of the technology curve. People are going to go out, there's going to be more services performed, but it'll take a while for the savings from the other diseases to kick in. So we do expect a small increase in costs the first year, and then we'll expect savings with that after that. Thank you.
Next slide, please. Okay, so a little bit about integrated behavioral health. Again, it emphasizes treating the whole person. And that's important because of really comorbidities. 70% of patients with the behavioral health disorder also have a medical situation. And then pretty large number, 30% of those with medical disorder also have a behavioral health comorbidity. So it's often not the case that you have this isolation of behavioral health without needing to treat physical symptoms as well. Potential benefits of integration are improved outcomes, a reduced cost of care, and then increased access to behavioral health care. I meant to mention at the beginning, the discussion preceding this one about detox and beds and the need for them. This obviously success in this legislation could reduce the number of beds that were needed. So sort of in the opposite direction of it sounded like things were going. And then legislative responses, really both on the federal level and the health level. Mental health parity was passed in 2008. I think a lot of advocates would say that there's still some gaps outstanding and patients aren't receiving the same level of access to care that they do on the physical health side. The 21st Century Cures Act, it included expanded funding for expanded mental health services, as well as some research dollars to do further studies. And of course, the National Suicide Hotline, to our knowledge, Delaware is the other state that has passed legislation similar to this. And then Maryland has done its own work with a work group to really look toward best practices with regard to behavioral health administration. And then the next slide. Regarding administrative issues, and this is really informed by a survey we did of the largest 5 carriers in the market, and all of them were very helpful in not short on words on answering some of the questions that we asked. A couple of things to sort of highlight that were commonalities among all 5 is they all cover behavioral health wellness, but with a cost share. So it's not free coverage. They have to pay cost sharing as they would a medical a visit. And telehealth is generally provided along the same lines. Some carriers offer online self-evaluation assessments where they fill out a questionnaire that may indicate potential behavioral health conditions. And interestingly, with regard to behavioral health wellness visits, there was a mix between carriers who viewed this as a primary care visit versus a specialist visit for both tracking as well as potential cost share differences. In current status, it could be that there are some cases where if it's recorded as preventive, it may be seen as without cost sharing. Obviously, this legislation would sort of clarify that, and there wouldn't be some of that fuzziness. And then some payers also have a preventive coverage policy, which may or may not delineate behavioral health coverage in that. And trying to understand some of the concerns that payers had with such a mandate. The responses were interesting. Some payers, want integration as opposed to this sort of separate behavioral health silos, where you have sort of where you have 2 visits effectively, a medical visit and a behavioral health preventive visit. Interesting. One of the carriers provider to come out, I thought was interesting that there are behavioral health patients with acute demands, and this mandate could potentially sort of shift care to people seeing behavioral health providers who aren't necessarily in an urgent situation, and some of that could be handled at the PCP level. I think there's a variance in sort of behavioral health recognition among PCP, so that opinion's different among providers as well as the insurance carriers. Definition has to be clear along with the coding. And you can go to the next slide, but that's really the end of our presentation. And Joan and I would be happy to answer any questions on our work.
So before we have questions and comments, I was going to ask Ben, since this is a mandate report, maybe the first one for many of the new commissioners, to just talk about what this report is here for, what we're supposed to do with it, why we're doing it, and how we should evaluate whether to approve this report or not.
Mr. Chairman, how much time do? Are you allowed?
Test, can you cram that on to like maybe a minute?
So the backdrop of this is prior to the passage of the ACA in 2010. The Maryland Healthcare Commission had authority over the small group market in Maryland. We said the benefits of that package, of course, MIA had responsibility over the carriers who sold that. But it was, the reason that happened was that the belief was that small group was broken. We developed expertise in insurance mandates as part of that, because the commission would could selectively look at benefits that had been approved and say yes or no on whether that benefit needs to be put into small group market benefits. As a result of that, the legislature recognized that we had a certain knowledge and responsibility, and encoded in the insurance article are directions for the Healthcare Commission to consider mandates that were not passed in a previous legislative session if we received notification from the chair of HGO, Health Government Operations Committee, or Senate Finance Committee before a certain date. And we were told to do a broad assessment that looks at financial, social, medical factors of a mandate. We modeled this kind of after what, and I'll say this slowly because you might want to Google it, the California Health Benefit Review Program that does something similar in California, but they look at mandates while the legislature is in session, have to turn it around very quickly. We look at mandates that failed, but the rule on mandates is that legislators will give it 2 or 3 tries. So if something comes in, surprises leadership, and the sponsor says, hey, I'm going to introduce this next session, it was damn close, or something to that effect, and well, we want to have some real information. So we're then kicked into gear. After the ACA, because of the way that essential health benefits was developed, there were strong disincentives for putting new mandates in state health benefit programs or state law for about 4 years. We began to see that change about 2018, and mandate requests started reappearing, and then we started getting letters. This year, I think we've received 5 or 6 requests. Some of those we've told the chair, they're not timely. We can't do this full social, medical, financial assessment with the aid of an actuarial firm, and we'll just give them a kind of a preliminary estimate, and that's it. But the key question, has been who would pay for those mandates, because under the ACA, benefits that are not included in the essential health benefit recognized by CMS and applied to the state must be reimbursed by the state back to the insurance carriers and the beneficiaries who paid that quote unquote higher premium to get that benefit. That's never happened. And I think part of the reason that we're seeing benefit coming in now is that many observers perhaps incorrectly have assumed that CMS is never going to do that. They've recently introduced guidance that said something a little different, but it is true that during the Trump administration, no what are called defrayals were imposed, and we haven't seen any in the first 3 years of the Biden administration either, but they are withholding their ability to do that. So we expect more to come. We expect that that you will be asked to do more of these. It is, I think, useful. I think a better use of our time is actually what we call our 4-year study, which you'll be seeing later this early next year, which looks at the cumulative impact of all mandates, which is more of a throw cold water on the face of the legislators, because they see cumulatively what it's costing. Any one of these individually is going to be, a very modest impact on premiums. That's not to say, that it's not considered, but the scary part is the cumulative impact on premiums, not the cost of any one mandate, which in almost all cases has some deserving population that's going to benefit. So that's how it happened. That's why it's a legacy duty of the commission. But given mandates are starting to reappear, I think it's a service that the legislature needs again.
And when we're approving the report, what we're not recommending or that the mandate be adopted or rejected.
Correct.
We are approving that this is a report that meets the things that we are supposed to report on about the mandate.
That's correct.
With that, do any commissioners have any comments, questions, or discussion? Commissioner Bazinski?
In your last statement, does this meet the standards of a report? I have become used to, and I've only been here a short while, of course, but I've become used to seeing, how much is this per healthcare premium, per patient or per citizen in Maryland. There's the usual per N is more than this is going to impact 0.2% of the healthcare cost or whatnot. It's hard to judge from the way this report is presented to know what really is the incremental cost to a purchaser of healthcare insurance, which is, I thought, was how these were supposed to be laid out when we get them to say, if we implement this, then each resident in Maryland will pay another 3 cents per month on their premium, or $10 per month on their premium. So to me, the format is not what I've come to expect, and I'm not sure how useful this format is in telling the story we typically like to have these reports tell.
Yeah, if we could flip back to slide 6, I think our analysis was financial, but was also social, medical, and administrative. Our conclusion really was the impact on premiums was fairly immaterial with regard, and that's listed. I think we went through the slide pretty quickly, but slide 6, the final line on that table shows the percent change in cost for each year, 2024 to 2028, and it ranges from 0.9% in year 1. There's an initial bump up, and then it reduces pretty close to break even in the following years.
But that the percentages of what?
Thank you.
It's the percentage of cost relative to insurers, which roughly translates to a percentage of premium.
Well, so is it a cost per premium per individual or a cost per total premium in the state?
It's per individual. So it's a per member per month. If you I think we went through the analysis quickly, but it's the numbers in the table are based on 1,000 members. So it's based on a per member per month analysis.
How much?
You tell us where, just for the commissioner's benefit, where in the report itself, not in the slides, that's referenced.
And just for presentation's sake, if we're going to present this to the legislature in the same format that it's presented to us, I find the slides with the financial analysis to be unreadable with my 65-year-old eyes.
How much easier at 49?
Yeah, also for 72. I had to take a picture to blow it up.
Yeah,
But thank you.
So
I could read the font.
he's going off.
I'm 53. I'd imagine you'd have the same comment regarding the regarding the report, but it's on the top of page 5 on the report in the report.
A lot of folks are looking, I was gonna ask is, so there are two things going on here. One is covering visits that are not already covered. And most carriers would cover a wellness visit. And another thing that's going on is not imposing cost share where a visit would otherwise be covered, but have a cost share. And under this legislation would still be covered, but would not have a cost share, which is maybe only $20. How much are you assuming there will be new visits versus there'll be just some visits that had cost shares and don't have cost shares?
So we assume that everyone that would normally have a visit, any kind of mental health, behavioral health visit, would continue to do so, and that their first visit would have no cost sharing. And then we assumed an increase in the number of people that were having visits and receiving care was 2% increase a year.
I think that's one of the things that we're not seeing that we're used to seeing as well. Usually we have elucidated all the assumptions that lead to your changes, and other than the microfilm tables, I don't see any, like, you know, we assume that there'll be, for every wellness visit, we'll have this many more follow-up visits, or will be that many less. You know, so I just don't see what your assumptions are to tell the story of whether costs are going up or going down. You know, do we assume if we do one wellness visit a year, mental health wellness visit, then no other mental health visits will be done? Is that an assumption?
Yeah,
We'll find things and we'll need to do more visits.
Yeah, so we do describe how much we expect to pay for behavioral health. We did not break it up into treatment paths. The numbers are too small for that to be meaningful, but we did base the information on what we know people, what the costs are, the total cost.
Yeah, and we delineated the key assumptions in the report. I'm not sure if it sounds like some folks are looking at the report versus the slide presentation, which we just showed the results in the slide presentation.
Oh, I'm gonna say, I think you need to retool this and bring it back to us in a format that's more consistent with other reports we've seen in this commission that help us understand the assumptions, changes in location and frequency of care delivery, and then their subsequent cost to the purchasers of health insurance, consumers of healthcare, in terms of a per member per month or whatever the common denominator we use in these reports, so we can have an apples to apples comparison, because this doesn't compare apples to the other apples we have.
Okay.
I guess that's my spouting off. If we want it to happen, I need to make a motion, but.
No, I don't know. I know some of the prior reports, which are back from 2019 are public. I think every actuarial firm's report formats are different. I don't necessarily want to plagiarize somebody else's formatting, but certainly want to present information in something you're used to seeing and makes sense to you. And so I don't know if we need to have a better sense of what your familiarity is, or how to kind of put things in a way you want to see it. Because from what you said, it's from the results and the assumptions, I think that's in there. It's just not in the way you're used to looking at it.
So what I would suggest is we table final action on this, ask Axine to bring out the key findings. I think that the commissioners brought up key points that, if they're having trouble finding this, they likely are going to meet rivals that are going to have an equal hard time finding it, which is the General Assembly. And I think Axine's done a good job on this. I think putting it forward in a way that's a little going to be more digestible to non-actuarial professionals would be helpful. And that's not to, I think, given we're going to see 5 of these, getting an early alert on this will help us. Axine, I think, is doing one more and give us a chance to kind of work with everyone to get a common format that I think breaks out the key points that the legislature wants to see in the executive summary. And I take that, ask Axine to take it back. And we would bring this forward along with, I believe we have 3 others at the separate. We wouldn't ask them for a presentation, but we'd ask the commissioners to take a look at the format and approve it with the other 3. And in the meantime, I think a good suggestion is to work harder at standardizing this. We do historically, this work was done by one actuarial firm, and we are told by the legislature to, that it is to be done by an actuarial firm. That, but once these stopped being such a big issue, we halted that procurement. And this year we actually have 4 actuarial firms working. So that really highlights a point that we should have been mindful of. So I appreciate you doing that without saying too much to Axine, because I did see this ahead of time, so I take ownership as well. That I think the points that are being raised, that it needs to be more consumable, is a good one.
And so you and your staff will meet with Axine and the other vendors to help them present in a manner we can digest.
Yes.
With that in mind, given that we've read this one and it's going to come back, I'd like to get, if commissioners have other thoughts or comments on this report in front of us, this would be a good time to give them out for revisions. Is that Commissioner Stoughton Duncan?
Yes, this is Commissioner Stroughton Duncan. I would just say, no worries. I thought, I like the points hit on the report, but I do agree that if we can bottom line it in detail of the information that was just discussed, I think it'll be really helpful as it moves through the different review processes.
Thank you. I had a comment on the integrated behavioral health discussion. I think it's important to put in there, but we didn't, the report doesn't close the loop that this is actually not integrated behavioral health. This is sort of disintegrated behavioral health, because if you built the wellness visit into the primary care visit every year, that would be integrated behavioral health, where the doctor, when you get the person in there one time, they're able to talk. So to the extent it's a point to be made, I think we should also sort of, it kind of implies that this is part of that. And I really don't think that the wellness visit as a separate visit with a separate provider is really integrating behavioral and medical health. It's sort of going in the opposite direction. So that would be my comment, is maybe something closing the loop when we discuss that, where that fits.
I would second your comment. I bit my tongue initially on this as a primary care physician, but we do a lot of mental health screenings as part of a wellness visit. And the ones that are listed at United States Preventive Service Task Force, USPTSF, grade A and B recommendations, screening for depression, anxiety, and substance use disorder. That's part of adult medical annual wellness visits. Children up to age 18, part of their standard, evaluations for wellness. So yes, and integrated sometimes means having a psychologist in the same practice as primary care providers. Sometimes it means having behavioral health issues integrated into a primary care visit by the same physician. And so probably clear definitions on that, and whether or not that's included in this, or as you mentioned, is this analysis a separate line of services rendered by mental health specialist? That should be elucidated as well.
Or from what I'm hearing you say, this may or may not be integrated behavioral health, depending on how they do it. Like, it's kind of hard to tell just from.
I think they need to, define how they are looking at it, and then we could work off of that. Because I think there's not universal agreement as to definition of that term. So I think we need a functional definition for the sake of this report.
This is Commissioner Bandari. I have a suggestion. I think it's very important to have at least one or first face-to-face meeting. You can see how the patient gestures are. That's very, very important for psychological or psych-related illness. I think televisits are good, but not very useful. I think good for doctor's pocket, may not be good for the patients.
To Dr. Brzezinski's point, I think the starting point would be whatever definitions were in the proposed legislation, right? And then the actuarial firm would say, here are the assumptions that were in that legislation, and our numbers are based on that. And so we could then have the discussion of future legislation if that definition is good or not.
That's a really good point.
Great. Any other commissioners? Going once, going twice with that. Thank you, folks, for our folks at Axine. We look forward to seeing the next round. Thank you.
So I just before they leave, the question of defrayals has come up recently, which for mandates that would really not expand benefits. My view is, maybe expands benefits, but do you have an opinion about that?
For us? Or
That's
for Axine?
for Axine.
I heard something about frails.
Yeah, do you think that this is going to trigger, in your opinion, reaching the essential health benefit rules regarding expansion of benefits beyond EHB? And I think rather than having a pause, I think what we would ask all of our actuarial firms is to provide a judgment on that in the report.
That makes sense.
That rather than, if you haven't thought about it, to think about it. So
Yeah. Okay.
Okay.
Thank you, Ben.
Thank you.
So then we're not voting to approve this.
So we've tabled it and then we'll come back. We'll move on to agenda item number 6. No, I'm kidding. Shankar. Agenda item number 5, 2024 MCDP Data Submission Manual. The Maryland Healthcare Commission is required under Comar 102506 to publish the medical care database data submission manual annually by November 21st of each year. This manual provides specifications, technical information, and recent updates to payers for the reporting periods in the subsequent year. Before posting the manual on the commission website, the manual is presented to the commission by MHCC staff seeking approval of the new manual. Shankar Mehta, Chief of Cost and Quality, Center of Analysis and Information Systems, will give an overview. Shankar, you have the floor.
Thank you, Mr. Chairman. Good afternoon, everyone. As Mr. Chairman described, the commission is expected to publish a data submission manual to payers for the collection of healthcare services data that is provided under the Maryland contract or to the Maryland residents. This manual provides guidelines on the technical specifications, file layout, and definitions necessary to filing the required reports. Payers refer to this manual to find out the reporting deadline for each quarter of the subsequent year. And as per the regulation, the commission is expected to post this manual to the commission website by November 21st and update the information in the Maryland register. Next slide, please. Yeah, and some of these initial slides may be familiar to the audience who have listened to this presentation before. So please bear with me. The regulation code specifies that any commercial entity with at least 1,000 total lives covered, as reported to the Maryland Insurance Administration. I want to pause. Could we please move on to the next slide, please? Yeah, thank you. Yeah. Okay. So So these entities include the life and health insurance carriers, health management organizations, third-party administrators, pharmacy benefit managers, bureau health administrators, qualified health plans, and qualified dental plans. We collect membership data or eligibility data on the characteristics of the members enrolled under the health plan. The claims dataset contains reimbursement information for services from providers, facilities, pharmacies, and dental offices. The provider directory contains information on the healthcare practitioners and suppliers. Besides this commercial data, we also collect public data such as the Medicaid Management Care Organization and fee-for-service data from Hilltop Institute. The Medicare data is acquired through a state agency data user agreement with CMS. Next slide, please. So based on the waivers we have received in the past few years, we updated the length of encrypted enrollee identifier, servicing practitioner ID, prescribing provider ID, prescription claim control number, and drug quantity so that we can meet the wide range of data submissions submitted by the different payers. In addition, we also added diagnosis code 11 and 12 and the procedure modifier codes 3 and 4 based on the recommendations from the new vendor OnPoint. And all these are the minor changes that would not have any impact on the current submissions. Next slide, please. Thank you. So starting this year, the Maryland Healthcare Commission began collecting the alternate payment model data from reporting entities who have value-based contracts in Maryland. This data collection is intended to meet the requirements of COMAR 1025-06-14 to develop a non-fee-for-service expenses report and incorporate the information and instructions for collections into the Commission's annual update to the MCDB submission manual. And for 2024 reporting cycle, MHCC requests that the eligible reporting entity include data for the calendar year 2022 and 2023 to assess the APM arrangements. This allows for the final year 2022 data to be submitted with 21 months of runout and to establish an accurate baseline, and 2023 data with 9 months of runout. To ensure consistency in data collection, we have included quality assurance memo and a frequently asked questions in the manual. The quality assurance memo provides summary of member months, total medical expenses, number of unique providers and contractors for various HCP LAN category contracts to ensure that the submitted data values match with the reporting entity's source system. The frequently asked questions section provides detail about requested data elements and clarifies information about how data should be submitted in a standard format. HCP LAN category 3N or risk-based payment and 4N or capitated payment category contains payments that are not linked to quality and appropriateness of care. This data is not required. Next slide, please. So we updated the file naming convention to identify each payer file in a standard way. All non-claims payments made during the performance year will be attributed to the same year regardless of when they were actually paid. The instructions for worksheet, financial and financial episodes have been updated to exclude HCP LAN categories 3N and 4N as previously stated. When reporting data, provider level information should be aggregated under the billing provider organization. We have included examples to help identify associated membership to contracts with prospective contract level payments. For worksheet, financial episodes and procedure-based episodes should be classified as HCP LAN category 3, while condition-specific episodes should be classified as HCP LAN category 4. Additional questions have been added to the notes worksheet tab to provide clarity on data submitter responses. Next slide, please. So upon Commission's approval, we will post the final version of the manual to the Commission website. We'll conduct a training session with the payer representatives in early January next year. And these changes will be implemented beginning of April 2024 for the first quarter of 2024 data reports. This concludes my presentation. Thank you.
Are there any questions? I have a question. On the quality reporting, I guess I see what we have here, and it's not so much an objection to these things in the manual, but how are we accurately capturing the full spectrum of value-based programs based on quality? I'll just give you a few examples, right? We've had in the past programs with quality used to calculate the incentive, programs with a quality gate, where if you don't meet certain quality thresholds, you just don't get an incentive. Those are built into the rules of the program, not the data. And then you have like a PCMH program for all primary care docs that has a set of rules that's applied to everybody, or you have what I've seen with large hospital systems. They create a separate risk-bearing entity. They have a ACO-like structure. It encompasses all like providers affiliated with that hospital in any way. It may have multiple different kinds of incentives and an overall incentive. And for something for Care First to enter in that wouldn't involve 4 or 5 different carriers, self-insured, commercial, all market segments, all lumped into this one risk-bearing entity for this major hospital system. How are we capturing all of those slices in the all payer claims database, which is really just collecting like insured claims for Maryland? Like,
sure, Chairman, I will take the first step and
yeah,
please help me here on this. I mean, as you explained, it is a very complex thing, and that's why what we initially thought that our approach would be to invite all the payers to basically learn from them, like, you know, in what way we can collect this data. So we started out with having an initial list of quality measures that we thought might be helpful to paint the picture of the value-based financial and the quality so that we can better present the information. And we started out with having the initial set of quality measures, and we brought that up to the payers representatives, and we had the meetings with each payers. And based on the responses, what we got, as you explained, it is very complex, and it is they're really struggling to provide that information. And based on that information, we kind of came to a conclusion that in the initial few years, we are gonna take out the quality component out of the scope of this value-based, and we're going to focus only on the financial component of this so that we can make it less burden for the payers, because this is a new territory that we are exploring, and we want to start with what is all the low-hanging fruits with this. So we kind of agreed upon to focus on the financial. But yeah, quality is something which we all agree is going to be very complex to collect. And when you would like to add on that.
Yeah, let me.
Sure.
So I think we kind of jumped over this pretty quickly, but we've mentioned the term HCP LAN a few times, which stands for Healthcare Plan and Learning Action Network, which is a collaboration of largely insurance carriers, providers, and health policy experts that got together beginning about 8 or 9 years ago to begin to figure out how we characterized the transformation of the healthcare system. They came up with a methodology called HCP LAN 1 through 4, in which these value-based programs are characterized into buckets 1 through 4, and it actually breaks down into increments within that. And that's our primary way we're characterizing value-based products today. I think we're still a ways off in terms of capturing quality, but it's all done in aggregate. It's reported once a year, unlike the claims which are submitted to the Healthcare Commission through our contractor quarterly. These aggregate payments are done about 6 months after the closeout of a given calendar year, when the reconciliation on these value-based plans occurred, and we could get a clearer picture. This is an outgrowth of legislation passed in 2022, which set in place in Maryland, permitted in Maryland for the first time, two-sided risk programs. And the legislature said, yeah, this is good. We think this is the direction healthcare delivery and payment is going, but we have great interest in the magnitude, the pace, and who's benefiting from these programs. So they directed MHCC to collect this information and report back to them on an annual basis on how things are evolving. To the point about quality, I think we recognize that's going to be a hurdle. If it was up to me, I would rather have the payers apportion it somehow, some way into claims, so you could figure that out. But a lot of these value-based plans are really not, are not equipped to do that, and thus we're getting an aggregate report. It's going to be, a challenge the first couple of years, as even within, a category, let's say an HCP land 3.B, that their 3.B from Cigna, does that look the same as the 3.B plan from Cigna? And the chair already answered no. We know that for a fact. So there's going to be some careful thought into how we present this. But the goal of the legislature is to see how these plans take root in Maryland. Are there benefits to all participants, or are there certain types of providers that can't benefit, or others that benefit excessively? So hope that helps.
It does. I would just add the plan for the same carrier for one large hospital system could be dramatically different, because the individual hospital systems, they each have their own view on what quality is and isn't, and how it should be. And those could be very hotly contested line by line negotiations. So even like Aetna's programs, don't know anything about them, but I doubt that Hopkins and UMS have the same one, just because each of those systems is going to approach it. So not to add to your burdens.
But I'm going to add to your burdens.
But I'm going to add to your burdens. So it'll maybe what we do with the data once we get it is. Anyway, that was my cheerful thought for the day. Does anybody else have any questions, or I'll call a motion? With that, do I have a motion to approve the 2024 MCDB data submission manual?
Thank you.
I heard, was that Commissioner Stroden Duncan?
Motion.
All right, and second, great. All in favor? Aye.
Aye.
Are there any opposed? Passed. Thank you. On to agenda item number 6. Health Information Exchanges, Privacy and Security of Protected Health Information, and Kumar 102507, Certification of Electronic Health Networks and Medical Care Electronic Claims Clearinghouses, Proposed and Emergency Regulations. In 2023, seems familiar, the General Assembly passed House Bill 812, Health, Reproductive Health Services, Protected Information and Insurance Requirements. The law prohibits the disclosure of legally protected health information by health information exchange and electronic health network entities operating in the state. The MHCC is required to develop emergency regulations to support the law. The Commission adopted emergency and proposed amendments to Kumar 102518 and Kumar 102507 at the October 19th meeting. After the October meeting, the Maryland Department of Health withdrew and repromulgated their proposed regulations. Staff will present additional amendments to the regulations to support the law and to stay in alignment with the MDH regulations. As a reminder, Commission regulations must be reasonable and be consistent with the letter and spirit of the law under which the Commission acts. Anna Gribble, Program Manager in the Health Information Technology Division, will present on the amendments. Joining Anna at the table is David Sharp, Director of the Center for Health Information Technology and Innovative Care Delivery. David and Anna, you have the floor.
Hey, good afternoon, everyone. So some of this, what we'll begin with is a bit of a refresh, just a level set, and we'll recap a bit of what the chairman just noted. As you recall, at the October 19th meeting, staff presented on the proposed amendments to the regulations, and those amendments received approval from the Commission. After, in the days that followed that particular meeting, as the chair noted, the Maryland Department of Health altered their approach to developing draft regulations to include a narrower set of codes for abortion care and eliminated the technical guidance document that was incorporated by reference into their regulation. The action taken by the Maryland Department of Health requires MHCC to reconsider select amendments to the regulations governing health information exchange, organizations, and electronic health network operating in the state. So before Anna presents the proposed amendments, I'll take a few minutes to provide remarks about why the law was passed and what the regulations will accomplish. Next slide, please. So to level set a bit more, since the Supreme Court's decision in the Dobbs versus Jackson Women's Health Organization case back in June of 2022, some states have enacted laws to ban abortions. Healthcare consumers, physicians, and other clinicians in these states face significant challenges in receiving or delivering comprehensive reproductive health care. Maryland law supports physicians and other clinicians who provide reproductive health care services and consumers who seek these services, especially those individuals in communities disproportionately affected by inequitable access to quality health care, without fear of prosecution or threats of violence. Approximately 16 health information exchange entities and 29 electronic health networks operate in Maryland. HIEs and EHNs enable electronic exchange of protected information securely for treatment, payment, and operations. The law limits HIEs and EHNs from disclosing legally protected health information, which means reproductive health services, medications and supplies related to the provision of abortion care, and other sensitive health services as determined by the Secretary of Health based on recommendations from a Protected Healthcare Commission, which is a stakeholder advisory group that was established by the law. The law also requires MHCC to adopt emergency regulations. That's what brought us here in October and brings us here today. Next slide, please. On this slide, I will mention several aims of the regulations and challenges associated with the law. The regulations establish safeguards for legally protected healthcare information, enhance privacy protections for physicians and other clinicians that lawfully provide reproductive health services, preserve access to and quality of reproductive health services, empower patients to have more control over their health information, and support future changes made to the restricted code list, which is the list developed by the Maryland Department of Health. Several drawbacks of the law include potential patient safety risk posed by limiting access to certain information previously available for treatment, the need for increased awareness among physicians and other clinicians that certain information will be omitted from the electronic health record for select patients. On the technology front, HIEs and EHNs are faced with sizable challenges associated with rapid deployment of technology that restrict codes, need to design, develop, and implement a technical solution that restricts text-based information, a clinical note or attachment, or elsewhere in the electronic health record. And then to apply the technology across all user sites where the technology is often uniquely customized. This is an area where more work and time is needed by most HIEs and some EHNs to appropriately design, develop, and implement the technical solutions to support the law. And here I would pause and yield to our executive director to make any comment regarding technology challenges?
Yeah. I think our regulations, thank you, David, are geared to take into account that the implementation period, which we view between December and June of 2024 as a time when we're going to be working really very closely with the entities subject to these regulations to figure out what can be done on an interim basis, as many of them are going to work towards a longer term, more what I would call directed or controlled solution for the long term. I think that the short term may be one in which information is largely blocked. And as we move forward, we're going to see the ability for patients to be much more selective on how they choose to use this new right.
So just to make sure though, we've already adopted emergency regulations.
Yes.
We talked about last month.
Yes.
These are coming back. The question today is not whether I like these regulations. It's these changes, the additions and deletions to, but I think we should adopt these changes to the regulations that already exist.
The regulations that were adopted by the commission last month.
Yes.
Thank you. May we proceed?
You may.
Thank you, Mr. Chairman.
I want to make sure I was looking at it the right way.
Yeah, so we're, the decision that's going to be before us is actually quite narrow.
Do these changes make them better? Let's say it that way.
Yes. And I might add to that, Mr. Chairman, the changes that staff are presenting today were viewed by staff and our assistant attorney generals as necessary to make. And so that's what brings us before you here today. And with that, I'll turn it over to my colleague to present on those specific changes.
Thank you, David, and good afternoon, Chairman and Commissioners. So as a reminder, the 2023 law establishes protections for the disclosure of legally protected health care and requires MDH and MHCC to adopt regulations, as mentioned before. So next slide, please. And COMAR 102507 and COMAR 102518 are the existing framework to support implementation of the law. Next slide, please. You may remember in September, draft regulations were released for informal comment, and all combined 17 organizations submitted 133 total comments. And as discussed, the commission adopted emergency and proposed permanent regulations during the October 19th meeting, and staff presented the modifications in response to those comments at that time. And the new amendments presented today reflect the change in approach taken by the Maryland Department of Health to develop the emergency regulations that identify the initial set of codes for abortion care that HIEs and agents may not disclose unless the patient provides consent or for the adjudication of claims. So I'm going to provide a high-level summary of what the changes are to COMAR 102518 and COMAR 102507, and then go into detail so you can see the track changes versions. And I'll start with COMAR 102518. Health information exchanges, privacy and security of protected health information. Next slide. So here are the high-level summary of the modifications to COMAR 102518. We added 3 new definitions: adjudication of claims, health information technology developer of certified health information technology or developer, and 21st Century Cures Act. The modifications also amend the definition of legally protected health information as well as population health management purpose. The modifications move the due dates for HIEs to submit either an affirmation or an implementation plan to January, as well as adding steps to the process an HIE must take to request an exemption to COMAR 102518, as well as other miscellaneous non-technical edits. So next slide. So the first change we want to present today is the addition of the definition of adjudication of claims to Regulation 02. And this was based on feedback we received from stakeholders. Next slide. So another new
the feedback, I guess it seems like a fine definition. What was the feedback? What are we trying to address?
The feedback was to add the definition, to add a definition.
So the entire definition is new language.
The entire definition. And it's important for here, for the stakeholders, the concern is driven around what does adjudication claim mean? And under the federal requirement, federal law, HIPAA, adjudication is not limited to just I process the claim. It's the authorization, it's the referral, it's the utilization review. So it collects all those different phases and puts it under utilization or claims adjudication because it's a multi-pronged aspect in and of itself.
Thank you.
And on the screen now is the new definition. So this one's new as well for health information technology developer of a certified health information technology or developer. And this definition was added because it provides clarity to another new definition, or the updated definition, I should say, to health information exchange, which references health information technology developer. But next slide. So modifications on this slide reflect recommendations from the Maryland Department of Health. So the definition of legally protected health information was updated to specify that certain codes based on services provided after May 31st, 2022 are subject to protections established by the law, as well as the reference of the technical guidance document was removed given MDH's new approach to specify the codes in regulation. Next slide, please. And then the last update to Regulation 02 is the small update to the definition of population health management purpose. And this aligns with text that's referenced throughout COMAR 1025-18, as well as adding the definition of 21st Century Cures Act, which is referenced throughout the regulation, but we added the definition to help. Next slide, please. The modifications to Regulation 04 changed the due date for an HIE to submit an affirmation or implementation plan, moving it from December 18th, 2023 to January 8th, 2024, as well as adding the reference to the MDH regulations. So this extension provides additional time for HIEs to comply with the law. Next slide, please. So the modification to Regulation 09 adds a requirement on HIEs that are unable to comply with the regulations. So this includes the development and implementation of policies to ensure HIEs compliance through the execution of written agreements with participating organizations or business associates. And then every year, as part of a registration renewal process, HIEs must submit a written attestation by an independent third-party auditor attesting that the HIE has been in full compliance with the requirements of this chapter. The next slide, please. So those were the changes to COMAR 1025-18. I'm now going to provide the high-level summary of the changes to COMAR 1025-07 and then the additional detailed description as well. So COMAR 1025-07, certification of electronic health networks and medical care electronic claims clearinghouses. So the modifications include adding the definition of adjudication claims, amending the definition of legally protected health information, updating the biannual certification process, and then moving the due date for agents to submit the affirmation or implementation plan from December to January, as well as other miscellaneous non-technical edits. So next slide, please.
Fairly similar to what you did 1025-18.
Next slide, please. So similar, adding the definition of adjudication of claims to Regulation 02, again reflecting feedback we heard from stakeholders. Next slide, please. And then similarly, the definition, updating the definition of legally protected health information, specifying that May 31st, 2022 is the date of service in which certain codes are subject to protections established by the law. And the reference to the technical guide was removed given MDH's new approach. Next slide, please. So this modification to Regulation 04 updates when payment of an EHN certification application should be provided. And these modifications reflect the current procurement process and state processes that are in place right now. Next slide, please. The proposed modifications to Regulation 09 change the due date for EHNs to submit an affirmation or implementation plan to MHCC from December 18th to January 8th.
And this is an extension to allow EHN's additional time to comply with the law. Next slide, please. All right, so this concludes the presentation on the changes to the regulations. And next, I'll provide a high-level overview of next steps. So if approved by the commission, the amendments to the regulations are anticipated to be published in the Maryland Register next month as emergency regulations and as proposed permanent regulations. And staff plan to present formal comments received on those proposed permanent regulations to the commission next year. We anticipate at its February meeting. And to note that this timeline is tentative and subject to change. So next slide, please. So today, staff is requesting the commission to take action, the following two actions on COMAR 1025-07 and 1025-18, adopt as emergency regulations and approve as proposed permanent regulations. This concludes my presentation. We're happy to answer questions at this time.
Are there any questions or comments? Mr.
Yes.
Bliski, you have a question?
I have more of a comment. As I've contemplated this and had the chance to look at some of the code sets and contemplate some of the ramifications of this legislation, I've been concerned. I've been very concerned. I've been concerned about, neglected patient safety issues in this legislation. In healthcare, there's a patient safety initiative where if you see something, any member of the healthcare team, if they see something wrong, they can raise a red flag and everything stops in the OR, in the emergency room, anywhere. I would like to raise a red flag with this legislation. I've prepared some comments to elucidate so I don't talk long, but I believe House Bill 812 is the wrong tool for the job. Healthcare tools such as health information exchanges and electronic health networks are designed to promote the protected dissemination of medical information across providers and care settings to improve the quality of care, decrease cost, and improve patient safety. The Maryland legislature, through HB 812, is now trying to force a function of concealing and obfuscating information about medical and surgical treatment into a technology which is designed to do the exact opposite, as we have heard from 133 stakeholder comments. House Bill 812 will continuously be problematic in its technical implementation, as well as in its threat to healthcare quality, cost, and safety for Maryland residents. Furthermore, HB 812 is attempting to use Maryland healthcare law to address regional national threats to induced abortion access for non-Maryland residents. Maryland residents and providers have no legal barriers to induced abortion access within the state. Maryland healthcare law does not have jurisdiction beyond its borders, and subsequently, House Bill 812 will never be able to accomplish the true intentions of its sponsors without imputing an inordinate level of risk to all Maryland residents and providers who rely on HIEs and EHNs for completeness and transparency in the transmission of health information. Additionally, HB 812 gives no provisions for identifying and rectifying the numerous unintended consequences to the quality, cost, and safety of care delivered in Maryland. Although there may be a future reality in which HIE technology allows patients to control the release of their medical information at a granular level, that future reality requires explicit transparency to the public and to the providers and patients, as well as directed consent by informed healthcare consumers. As a practicing physician who has seen direct patient harm resulting from the first step in parsing medical treatment records in the context of methadone therapy for opioid use disorder, I believe parsing out information about medical and now surgical therapeutic interventions will result in more acute and severe harm. Additional unintended unaddressed consequences include the handling of ancillary testing related to induced abortions and in the non-ICD-10 codified documentation of induced abortions, such as in medical orders, in the clinical nomenclatures of the G's and P's of pregnancy care. That's a shorthand documentation of pregnancies and their outcomes used by clinicians worldwide. And it does include documentation of spontaneous and induced abortions, and that is not considered in the code sets. Also, what happens when parsed medical records from Maryland are exchanged with entities outside of Maryland and that data is reconciled? Will the parsed medical record in Maryland supersede information from other states' records, effectively erasing data from other states' HIEs? This phenomenon is already seen in HIAs, in vaccine reconciliation and medication reconciliation. I see it on a daily basis. I feel it's important to advocate on behalf of those who do not have a voice at this table. For patients and providers in Maryland who do not have the freedom of choice within HB 812 of how their medical record is parsed. As I said previously, I believe there may be a future reality where patients can release their medical history in a granular manner to health information exchanges, but that future reality requires a great deal of transparency as well as self-determination of the patients making the choice of what to release or not release. Additionally, healthcare providers require explicit education as to what may or may not be contained in the HIA medical record. This has been a failure during the parsing of methadone treatment outside of prescription drug monitoring platforms. Therefore, at this time, I recommend the commission vote to not implement the regulations asked of us and return an opinion to the legislature to rescind House Bill 812 and instead use Maryland Criminal Code to provide the desired legal protections for induced abortion services rendered by Maryland providers to out-of-state residents. I believe HB 812 gives a false assurance of those protections since it simply hides the fact of these services being rendered rather than protects the fact they're being rendered. I believe the model afforded us by the state of Delaware can help guide us. As in the comments letters we've received, Delaware does not have a restriction on information being populated and transmitted in HIAs and EHNs, but rather there are robust restrictions on the use of legally protected health information for the purposes beyond direct patient care. I believe that would give the protection desired by the sponsors of HB 812. So in summary, I do not believe that using a healthcare tool to address out-of-state civil and criminal risks at the expense of patient safety of our fellow Marylanders and compromising the informational fidelity of our Maryland residents is inappropriate use of current HIA technology. I believe this represents the wrong tool for the job. So thank you for hearing my position on this.
Thank you, Commissioner.
Thank you.
Any other commissioners? I think, for me, we can ask our Attorney General, but I think we are instructed to pass regulations on it. I have sympathy for physicians, don't get me wrong, but I think in terms of what we're supposed to do under the law right here is pass the regulations to implement it. I do agree we can comment back on it. It's the best way to address what really is a real problem. I don't think anybody in the discussion here has said it's not a problem, right? Like there's really something that needs to be addressed with respect to folks. We don't want women getting in trouble or ill repute or anything else for getting legitimate healthcare services in the state of Maryland. But I think from my perspective, any commissioners come in, I think we have an obligation to do what the legislature said, which was do our best with these regulations, even if we don't like the bill. For that, looking narrowly at what I'm asked to do today, I'm asked to see if I like these changes to the regulations as they exist. That's my thoughts. I don't know if any other commissioners have thoughts or want to comment.
I just always appreciate the clarity on both. I absolutely agree with Commissioner Buzinski, but then you share, here's what I've got, to vote on. It's just like earlier, I was trying to make a decision. It was like, oh, we hear him trying to make the decision, but then this part is hands off. I do love moving forward if we could make the recommendation, even if they choose not to hear us. I like the record to reflect, perhaps it is another tool if they would like to engage with us. Love to do that. And we were going to.
Yeah, we haven't, so we discussed last month to include a letter with some reservations or concerns. I think that can still be shared with the sponsors or HGO. I think that would be the avenue at this point. Obviously, a stronger letter written on behalf of yourself, I think, is of course always permitted. It's not, on any issue, a commissioner should not represent himself as speaking for the commission, but if the common letter we would put together, which I do think that I would qualify it, Dr. Buzinski, by pointing out that patients can opt in. And I would think that in many, many cases, Maryland residents presented with the choices would say, there's no danger for me. I want information to flow as it does today. If you do have concerns, then you have this additional protection, which is not some hypothetical concern. It is actually real. And I would also say that from my understanding, certain providers did raise concerns, even though they were Maryland residents, about traveling to other states where abortion was prohibited, about their legal liability, even though they may not have actually delivered any reproductive health care to a resident of that state. The mere fact that they were and we can come up with, there are all sorts of terms where these medical professionals been grabbed in another state. That was actually several reservations were raised by clinicians when we were talking about where a conference would be located. And some of them noted that given the types of work that they did, they would not feel comfortable traveling to those states for fear that they would be at risk. So I think even, this law is all very uncertain today, especially we're reacting to what other states are doing. I absolutely agree that if this was not being done in other states, doing this would make no sense.
I just want to bring to light that I believe there's patient safety issues, significant ones that will develop by the implementation of this law. And the law itself makes no, intent to identify, address, or otherwise attend to those consequences for patients. Because parsing the medical record, regardless of what the part of it you parse out, it has clinical consequences to physicians and providers who've learned to trust that as a source of truth. And without some active education or information or some sort of active way of it helping us identify what now or how now our EHRs are being limited, it does increase risk because we all sort of assume there's certain data there, and now suddenly it's absent through no action of our own.
And important to note that this information would still be in the EHR if the clinician chose to put it in. It cannot leave that EHR. So hypothetically, I am treated at the University of Maryland and I go to multiple facilities. Their instance, and they use the Epic EHR, they're considered one instance. That information could be shared with treating clinicians. However, if that information was requested by a clinician at MedStar using, they have a Cerner EHR, that information, because it would go through the functionality of health information exchange, would have to be blocked unless a patient gave an appropriate consent. So you stay in the same system. It's considered under the definition in the law, it's considered in an EHR functionality, and only when it's transferred out is it in information exchange.
Perhaps if we're going to send a letter of comments, we could make a positive comment that there's an educational component, right? Patients in Maryland be advised that they could, I forget if it's opt in or opt out, it would make, in other words, opt out, right?
Yeah, they have to opt to information sharing for reproductive health. They have to opt in. I would
Okay.
share.
So an educational component where if you're in Maryland, you can opt in, and then it doesn't impact them. And for providers to ask, if somebody comes in, have you opted in or out? And then the only other comment I've got is that I don't think that the criminal law provides any better option here. I think you had mentioned that perhaps we could move away from this and I think that brings its own set of significant problems as well. Significantly doesn't provide any help for the people that are coming from out of state.
I thought Delaware had a pretty good solution from what it sounded like, and I wasn't quite sure where in Delaware code it was, but it didn't didn't limit information exchange, it just limited the use of it.
Are there any other commissioners that have questions or comments? I have a question for you about the text of the amendment.
I'm sorry.
Regulation 9, I think it's slide 12. As this additional, if the HIE is reasonably determined it's unable to independently meet any requirements, it can hire a subcontractor. Now, last time we talked about, well, what if we don't think they're not going to be able to do this by the deadline? There were exceptions. Are we taking those exceptions away, or are we adding this additional, you can also have a subcontractor do it for you?
So if you just hold us for a second, so if we're looking at, this is G underneath.
Yep.
of 9. Okay, so the purpose here is to really, because it mirrors what the federal government does under some of its programs in healthcare, which is if the entity in which is responsible for implementing is not able to implement it because it's something that would be handled by a business associate or one of their users, the regulations at the federal level hold the entity responsible for implementing these, it's akin to a chain of trust agreement, which means it passes through from the organization to its partners downstream, but the organization is held accountable to making sure those agreements are in place. And so we are aligning this, so we're not out of lockstep with how the federal government.
So this is a subcontracting provision. It's not a provision messing with the technology does not allow this at this time. There's by the due date, the things that we discussed last time, right? Where the carrier may not be able to do it, and we were going to look at it, and we weren't going to assess fines because they're going to have a runway. All that stuff is still there.
Still there.
And you've just added this sort of protection for if they need to subcontract it, this is the rules they should follow.
Correct, because it actually protects the organization who's named in the law for the fining, meaning the HIEs and the EHNs. It permits them to pass through that requirement to their business associates or to their users. And so it ensures conformance, and then it also takes away the risk of having an entity responsible for something they can't control.
Thank you. If there are no other questions or comments, I'll call the question. Right, I'm sorry, do I have a motion? There are two motions here. Do I have a motion to adopt COMAR 1025-18, Health Information Exchanges, Privacy and Security Protected Health Information, and COMAR 1025-07, Certification of Electronic Health Networks and Medical Care Electronic Claims Hearing Houses as emergency regulations?
So moved.
Commissioner Jensen, do I have a second?
Second.
Commissioner Douglas, thank you. Any additional discussion before we vote? All in favor?
Aye.
Are there any opposed?
Aye.
Oh, I'm sorry. Sorry about that. Are there any opposed?
I'll stand opposed.
Commissioner Budzinski. Motion passes. Do I have a motion to approve the COMAR 1025-18 Health Information Exchanges, Privacy and Security of Protected Health Information, and COMAR 1025-07 Certification of Electronic Health Networks and Medical Care Electronic Claims Clearinghouses as proposed regulations?
So move.
Commissioner Douglas, thank you. Do I have a second?
Second.
Commissioner Gilmore, thank you. Any discussion? All in favor? Oh, I'm sorry. Go ahead. Is that Commissioner Blake?
Yes, I have one question. Are we proposing with modification or some type of amendment?
So, I understand this to propose with these amendments as proposed regulations, the amendments are going out for public comment before they come back to us as final. So once we just.
So, it does seem odd to commissioners that we're doing two of these. So emergency regulations only remain in effect for 6 months. So, and after that point, if no other action is taken by the state, it reverts back to the previous version of the regulations. So it is our practice when we're directed by the legislature to adopt emergency regulations, and the Administrative Executive Legislative Review Committee, AELR, which takes a look at regulations and their conformance with the law, would say, you have to have a regular regulations follow on, or else it is kind of a pointless exercise because emergencies expire after 6 months under Maryland law. So that's the kind of odd situation we're in today.
Thank you. Any other questions? That, I will call the motion. All in favor? Aye.
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 Are there any opposed? Opposed? Thank you, Commissioner Pacizzi. With that, the motion passes. Thank you all. Thank you, Mr. Chairman. Back to agenda item number 7. End of our action items. MHCC's Facility Planning Authority using existing law to address health equity. The next agenda item is an overview of MHCC's existing authority to address health equity and statute and regulations. Presenting will be Winnie Hawk, Director, Center for Healthcare Facilities Planning and Development. Winnie, you have the floor.
Thank you, Commissioners, Mr. Chair and Commissioners. Last but not least, I'll try to move quickly through this, but please, I'm happy to take as many questions as you have. What I want to do today, I'm here to just to review what is currently on the books in our statutory and regulatory guideline in the provisions that guide the commission. What's existing as it relates to health equity. Next slide, please. So I'm going to touch on the 4-year strategic priorities for the commission, the new review criteria that was just reviewed recently in the procedural regs, and then the existing statutes and regs. Next slide, please. So the commission has made it a strategic priority for the next 4 years to make to use its healthcare facility regulatory authority to enhance equity in healthcare delivery. That means we're going to focus on access, quality, outcomes, and cost. The first 2 of these strategic priorities relate to health equity. Next slide, please. So what do we mean when we talk about health equity? I thought it would be helpful to show, the different definitions. This slide is a bit busy, but it shows how different organizations, the CDC and Robert Wood Johnson, define health equity. I think the common themes here are that there's fair and just opportunity to be healthy and to overcome and remove obstacles that relate to improving health outcomes. Health equity is also a primary goal in the Maryland Total Cost of Care model. And in that, you can see they've launched the Maryland Primary Care Program to improve access. And then CMS has the all-payer health equity approaches and development, which is the AHEAD model. And that's a new alternative payment model to improve care coordination in Medicare and Medicaid recipients. I think that the goal there is that fragmented care contributes to widening health disparities. So these are all efforts that are ongoing. Next slide, please.
Sorry, we need a point of clarification. The last bullet point, Maryland is planning to apply in one of the initial 2 application cycles for the AHEAD model.
I think so, yes. I'm not sure that, in fact,
Planning is the word that I would use today. As a matter of fact, the solicitation known as the NOLO, David Sharp is holding it up. It came out this afternoon for the first wave. I have not had, there's no commitment that we're going to, but planning is a good word. They have called out Maryland, Vermont, and Pennsylvania as states that CMMI thought were especially well suited to moving forward. There are lots of pluses and minuses with this. The NOLO today doesn't mean we should necessarily be caught up in FOMO. We need to think about it carefully on whether this all works out. Sorry to derail you.
oh, no worries. I just
We
wasn't.
need to remember YOLO.
Oh, okay. On this slide, as you're aware from previous commission meetings, there is a new certificate of need review criteria that relates to health equity. We've added this new review criteria, and this again furthers the commission's goal to have a health equity focus in the use of our regulatory authority. So as of December 1st, That will be the effective date of these regulations. This will be a component of certificate of need reviews. Now, I don't believe we have any applications that will be coming in until February, so that will be the first that you will see, like an assessment of how this will be measured. But an applicant is going to be required specifically to address how a proposed project affects or improves availability, accessibility, and quality of care among the different populations in the service area of the project or the facility. Next slide, please.
Can I ask one question about that? Are we also considering, I mean, if somebody else comes along and says this project will actually make health equity worse, I assume that would be.
I'm sure that, yes, if there's, I mean, that could potentially come in from a potential interested party in the application. I think we'd have to weigh all the factors. But I think, honestly, we will be working to develop how those measures will be evaluated. We haven't gotten there yet, but I think absolutely that could happen. So now we're going to go over the existing statutory authority. Next slide, please. This is just a quick review. This is what's in the statute, and as it relates to, it's just the general commission. First, in the purpose of the commission, generally, we have to promote financial and geographic access. That's 19103. And 19104 is the composition of the commission. And you can see there that there's not only there's a geographic balance of where the commissioners come from, but a racial, ethnic, and gender diversity balance. Next slide. So again, these are just the general duties of the commission. So when we appoint advisory committees, we need to have representatives of a varied group of representatives on these committees. In 19115, this enumerates the commission's specific duties in health planning. We will, evaluate projects both based on Title VI of the Federal Public Service Act, which essentially prohibits discrimination. And then the next category is provide analysis based on, we're going to look at the adequacy of services, distribution of resources, allocation, and healthcare costs. And next slide, please. In 19118, this is what deals specifically with state health plan and general state health plan guidance. This ties back to the duties outlined essentially in 19115, as it requires the state health plans, standards and policies that are used in the CON program to address availability, access, cost, and quality. Next slide, please. And in this particular slide, this is in general, this addresses circumstances where a certificate of need application is required. And those circumstances are specifically enumerated. But it also, I thought this was an interesting provision because it allows consideration of special needs and circumstances. So if it's not specifically enumerated, if a county can, where a medical service doesn't exist, is necessary, it can show a positive impact, and it can be more efficient and effective, it can be considered. Next slide. Now we're going to look at the regulatory authority, and just a quick review. I always look at it this way. The statutory law gives us the framework, which is essentially like the skeleton in your body, and the regulations are intended to provide the detail. So we're going to go into thank you. Next slide. This slide just simply demonstrates the state health plan chapters that have charity care policies, charity care and financial assistance policies. These are essentially written policies for the provision of charity care for indigent patients. This is to ensure access regardless of an individual's ability to pay. Next slide, please. This slide, it's a similar in vein. It's financial access for indigent and gray area patients. Essentially, it requires an applicant to establish a sliding fee scale consistent with an ability to pay. And it also, in the language in these state health plan chapters, it requires a commitment to provide a certain percentage or of facility days to indigent or gray area patients. So, and just as a quick primer, indigent patients are people who qualify for medical assistance. And gray area are those that don't qualify for medical assistance, but whose annual income from any source is no more than 180% of the most current federal poverty index, and who have no insurance. So we're trying to capture charity care, sliding scale, and the whole range of these chapters. Next slide, please. Or in these provisions. So these state health plan chapters either require medical assistance participation or an MOU. And the MOU is actually specific to long-term care facilities, to nursing homes. And so what does that mean? It requires a Medicaid MOU as a condition of CON approval. And an MOU, what is that? It's a memorandum of understanding that they will maintain a proportion of Medicaid patient days in the facility. So that is used as a tool to make sure that there's access to long-term care services for all Maryland residents. Often you'll see in our CON applications that there's a condition that an applicant is required. If they don't have an MOU, they're required to execute an MOU as a condition of approval.
Is it a percentage, Winnie, of the total beds available, or how do they come up with?
Well, so the percentage, the required Medicaid, I actually printed this out because I knew I wouldn't remember it. It's essentially they have to, the Medicaid program calculates the percentage. Ben, can you explain it simply? Because it's the most recent 3 years, you calculate the weighted mean of the proportion of Medicaid participation, and that's defined as Medicaid patient days divided by the total patient days for each jurisdiction and region.
And everyone follows that?
Yeah.
Okay.
Everyone follows it if they come forward to us with a CON. But if you never come forward with a CON, you may not have.
Correct.
Threshold. Now.
Oh, sure. Go
Yeah,
ahead.
so there are arguments about whether this is effective or not, because occupancy levels are such in Maryland for nursing homes that there are no issues of access theoretically. But I think this is important because it does apply to new facilities. In particular, when they come to us, they want a CON, we're replacing it, we're modernizing. We then say, will you commit to the Medicaid share, which people who say, well, there's plenty of capacity, but is it all, it's not all the same, it's not all good capacity. And what we're saying here is that facilities that are new have to conform as well. The formula that Winnie, I understand why you wouldn't want to go through it. The bottom line is that it kind of, it lowered the threshold a little bit. So some people complained that it was too high. So the end result is it lowers it below the average. That's what we were trying to accomplish. Give some people a little breathing space on the county-wide threshold, because that applies to everyone. The argument was to give us some time to gear up. So that was done in about 2007.
Yeah. Yeah, I think one of the things we do is we check the participants, are they compliant with their MOU? And in some circumstances, probably in alignment with what you're talking about, Ben, they can, if they're not meeting it and it doesn't reflect the jurisdiction, then they can renegotiate that with Medicaid. But Medicaid essentially monitors the percentages, and they're supposed to, and they're responsible for enforcement. But
yeah, I would say that we are the enforcing entity. If they come back to us and have not met the Medicaid commitment, we would, in information to the commission, make note of that and ask them what they are doing to come into compliance. Tracy's telling me to speak louder, so I will.
I thought she was telling you to hurry up.
That too, but we'll deal with that later. Anyway, yes. I think it is fair to say when he's being generous, that Medicaid has historically not been particularly enamored with this requirement for, reasons I can't discern.
No more questions? Then next slide, please. This is, again, another further explanation of the MOU, talking about it as a condition of approval and that it's used to assure access. Next slide. I think I've covered these points. And then there are other regulatory provisions like that are like, for example, residential treatment centers. Obviously, they're on the list to update because they're obsolete. I don't think we would use sex-specific programs. I believe that means gender-specific. So, or meeting special needs in the hospital state health plan chapter. There's provisions that relate to geographic and accessibility and non-geographic barriers. And that is travel time and mileage. The hospice has recently included a public education program, and that's a standard that is required to be addressed. But we haven't had a hospice CO in a while. And then again, comprehensive care facilities. I think I've gone over those. Next slide, please. And then lastly, an offshoot of the hospice, of the patient education, public education programs is the Maryland Hospital Survey that is done. And that adds data on race and ethnicity. And then one of my staff brought to my attention conditions on CON approvals. Now, this condition is the only one I could find. It goes back to 2005, but it was when Suburban Hospital had its open heart surgery approved. But they included a condition that was required an annual report evaluating the effectiveness of the outreach efforts, and with particular focus on African American and minority populations. So it's just,
who does that report go to?
it comes to the commission, and I think that they only had to do it for a certain period of time, and that time period has passed. So, but it's given me ideas for future conditions as we move into using this as a tool in the regulatory world. So it was an interesting find. So, but it's very old.
Well, that's relevant. 2005.
Next slide, please.
Yesterday.
I think that's it.
Some of us. What's this yesterday?
I think,
You started growing your beard.
Yeah.
I mean, I just wanted to close. I think that the pandemic has highlighted health inequities and has really supported the direction that the commission is going in this regard. So many states actually I did a quick search, and a lot of states are actually passing a lot of statutory law that are focused specifically on health equity. So I think we're on the right track. With that, I'm in my presentation.
Thank you. Any questions or comments? Thank you.
You're welcome. Thank you.
That we're gotten to our last agenda item. I appreciate everyone's engagement. I want to remind the commissioners and the public that the December meeting will be held on December 14th, only three short weeks away.
No way. Ouch.
With that, Ben, do you have would like to share any upcoming
Yes,
activities for December?
So we're actually going to have the plan right now. It's going to be tight, but we plan to have to bring two CON actions to the commission. That would be for the obstetrics program at Doctors Community Hospital in Prince George's County and the Shore Replacement Hospital in Easton, Maryland. Both of these projects have been in the works for many years, particularly the Shore project. And we hope we can carry this project forward, as well as the Doctors Community Health program, which will establish a new obstetrics program in Prince George's County. About 80% of deliveries in Prince George's County residents are delivered in hospitals outside of the county. We also will be bringing forward some of the additional insurance mandates. We've taken Dr. Blazinski, you may not have won on everything, but you made a good point with the mandate study. And
Not about winning, it's about the patients.
And we will have one on the treatment of alopecia. The, again, somewhat similar to today, the treatment, the application of the same cost sharing that applies to mammography to diagnostic and supplemental biopsies for breast cancer, as well as a similar parallel recommendation that would set minimal cost sharing for labor and delivery services. We will also have a presentation from Richard Proctor on the annual trauma report on the status of the fund. And Bridget Zumbro, former COO here, will come back and present an update on our user fee assessment. More on that later, what that actually means for people who don't. That's the formula that is used to determine the distribution of fees that stakeholders pay to the Health Commission's budget. We will also have at least 3 recommendation presentations. One on small assisted living, I mentioned that earlier. One on nursing home acquisitions, and the third on the recommendations for the trauma fund commission that MHCC and MIMS were called upon to convene. So it's going to be a meeting that will be some duration, but we'll try to move through it expeditiously. But a lot of interesting items. I also wanted just to conclude on what my update was, and that was to bring to your attention that we are changing our policy on the use of the APCD, the All Payer Claims Database. We have a much more robust data contractor today than we did in past years. We have a number of entities that want to use it, but don't have the capabilities to set up their own enclave. And we're starting out first with state partners, starting out with the Prescription Drug Affordability Board. We would are working with our contractor to give them access through our enclave. And we hope to also give access to 1 or more researchers from the Cancer Control Board at the department. They use what's called SEER data, surveillance early identification. It's a data system developed by the CDC, and they use that for tracking cancer. And they would be very benefited if they could get access to our insurance claim data to understand spread of conditions versus treatment protocols versus certain information that's in insurance claims that's not on these SEER databases. That I think the risk far outweighs the benefit. We're working with our attorneys to determine if we have to bring those forward through a DUA arrangement, or if we can, as they are state employees, do something in a more abbreviated fashion going forward. And lastly, I wanted to just make sure that we have everyone reaching out to us from the commission standpoint if there's questions on any issue matter that comes before you on the agenda, to reach out to me or one of the center directors if you need clarification. After the first year, what we would also like to do is reach out to everyone through a survey to ask commissioners what are areas that you are particularly interested in. The Healthcare Commission is touches virtually all of healthcare in Maryland, and we don't typically do it by ourselves, but we have a role to play, and it would be good, given we have 6 new commissioners, as well as commissioners that have been here for a while, to get a chance to refresh your interest, as well as, as commissioner, as the chair, mentioned today is we ought to get involved in AI in a more meaningful way, to give us staff feedback on ideas you might have. But I'm particularly interested in knowing everyone's, current interest areas, because there's a lot of things you could be interested in. It's really pretty hard to be interested in them all at the same level of intensity.
That's great. I think that's a really good idea, because what happens too is we'll periodically get a request, here comes the work group. And then, sort of think who would we ask to be on that? It's going to be great to have a preloaded list of, in addition to the vice professions, what they're.
And with that, I'll return to the NOLO. David's holding it there threateningly. The notice of funds availability, I think, is something like that, but funding opportunities, yes.
Nice.
We'll share that with the commissioners. We don't exactly know exactly how this spells out, but one thing of some import is that CMS is changing the definition of primary care. We understand that.
You're getting a new job.
I got a new job. I didn't even change chairs.
Congratulations.
Thanks, guys.
So we're gonna figure out what that means, because we've spent almost a year and a half working on a definition of primary care. It looks like a state could use its own definition, but we'll have to see what the solicitation says. So that concludes the update. Everyone have a enjoyable Thanksgiving, and look forward to seeing you in mid-December. It will be a good meeting. There will be some equity issues coming right into play. And
Great. So unless anybody wants to make a closing speech, I'll entertain a motion to adjourn.
So moved.
All right. Have a great Thanksgiving, everybody.
All right.
Commissioner Brzezinski, I'm pretty sure